So our mission today for you listening is to really understand this enemy, master the weapons, the drugs, and then develop winning strategies to protect patients.
Exactly. We're going from the absolute basics all the way to crisis management. And looking at this first source slide, you can see the battlefield laid out right there.
Yeah, that diagram of the aortic arch, the brachiocephalic, the carotid arteries, that immediately sets the stage. This is the central hub. The pressure battle is happening right at the core of the circulatory system.
So if the pressure's too high there, it's going to affect everything downstream.
Everything. Most critically, the brain and the heart. We are fundamentally defending the body's core infrastructure.
Okay, let's get into it. Before we can talk about fighting it, we need a crystal clear profile of the target. What is blood pressure? Now coming to the next slide, which breaks this down perfectly.
Right, so at its simplest, blood pressure is just the force of your blood pushing against the artery walls.
Oh.
And the reason we have two numbers is because it's measuring the full cycle of the heart's action.
And the source material has this great analogy that I think really helps. It compares it to a garden hose and a tap.
It's a perfect analogy. The first number, the higher one, is your systolic blood pressure, or SBP. That's the maximum pressure when the heart contracts, that big squeeze, what we call ventricular systole.
So in the hose analogy, that's when you turn the tap on full blast.
Exactly. It's that peak surge of pressure. And ideally, we want that number to be less than 120 millimeters Hg.
Millimeters of mercury. It sounds a bit old-fashioned, but it's just the standard unit of measurement, right?
It is. It's just a historical unit that's stuck around. It literally measures the force required to push up a column of mercury. So that's the peak pressure. Then the heart has to relax and refill. That's diastole.
And that gives us the second lower number, the diastolic blood pressure, or DBP.
Right. And if systolic is the tap on full blast, diastolic is the residual pressure that's still in the hose even when the tap is turned off. There's still some tension in the system.
Which makes sense. You need some baseline pressure to keep the blood moving through the tiny capillaries, even when the heart is resting.
You've got it. That diastolic number is so important because it tells us about the constant stress on the vessels. If that number is high and we want it under 80 millimeter Hg, it means the arteries are chronically tight. They aren't relaxing properly between beats.
So the gold standard is less than 120 over 80. It seems so simple for something with such a deadly reputation.
It does. And that brings us right to our next slide and the core threat analysis. Why is it called the silent killer?
The fundamental concept here seems to be about chronic stress. It's not a single event. It's this persistent, sustained high pressure that acts like a mechanical stressor on the whole system.
Think of it like running a car engine constantly in the red zone. Your arteries are designed to be flexible, to stretch and recoil with each heartbeat, but when they're constantly overinflated, day in and day out, that flexibility is lost.
They start to get stiff.
They get stiff, a process called arteriosclerosis, and the inner lining gets damaged. That's the microscopic wear and tear that ultimately leads to major cardiovascular disease.
And the source material splits this enemy into two main types. The first one, which it calls the mystery opponent, is primary or essential hypertension.
And that accounts for the vast majority of cases, something like 90 to 95%. Essential basically means we can't find one single identifiable cause.
So it's a mix of things: genetics, diet, lifestyle.
A complex interplay of all those factors. And because we can't cure the root cause, the entire strategy revolves around long-term management of the pressure itself.
But then there's the other type, secondary hypertension, which is a bit more, I guess, straightforward to tackle.
In a way, yes. With secondary hypertension, the high blood pressure is a symptom of another underlying problem. It could be a kidney issue like renal artery stenosis, or maybe a thyroid disorder, or an adrenal gland tumor.
And the strategic win there is if you can identify and fix that root cause.
The hypertension often just resolves. You fix the primary problem and the blood pressure normalizes. It's the ideal outcome, but unfortunately it's the minority of cases.
So for most people, it's that chronic primary type that earns the silent killer name. Let's run through the damage report from this slide. It's pretty sobering. It details exactly what happens when that pressure goes unchecked, organ by organ.
We have to start with the brain. Hypertension is the single biggest modifiable risk factor for stroke, period.
How does that happen? Does it just burst a vessel?
That's one way. The constant pressure can weaken a vessel wall until it ruptures, causing a hemorrhagic stroke. But it can also accelerate atherosclerosis, the buildup of plaque, which narrows the vessels and makes it easier for a clot to form, leading to an ischemic stroke. It's a dual threat.
Okay, so that's the brain. What about the heart itself, the pump?
The heart is having to work against this incredible resistance. Imagine trying to pump water through a narrow, hardened pipe. To compensate, the heart muscle, especially the left ventricle, gets thicker. It bulks up. We call that ventricular hypertrophy.
That sounds like a good thing initially, like it's adapting.
It's a short-term adaptation with long-term disastrous consequences. A thickened heart muscle becomes stiff and inefficient. It can't relax properly to fill with blood, and that's the path to congestive heart failure, or CHF. Plus, a bigger muscle needs more oxygen, which makes a heart attack, or myocardial infarction much more likely.
And the kidneys are next on the list. I imagine they're pretty vulnerable.
Extremely. They're basically just massive networks of tiny, delicate blood vessels, the glomeruli, that act as filters. Sustained high pressure physically shreds those filters over time.
And that creates a vicious cycle, right? Damaged kidneys can't regulate blood pressure properly, which makes the hypertension even worse.
Exactly. It's a downward spiral that leads to chronic kidney disease and, eventually, the need for dialysis.
And finally, the eyes. It's amazing how far-reaching this is.
The vessels in the back of the eye, the retina, are incredibly fine. High pressure can cause them to leak or bleed, a condition called retinopathy. In severe cases, it can lead to permanent vision loss.
So when we say systemic threat, we're not kidding. It targets your ability to think, to see, to pump blood, and to filter waste. It's a multi-front war.
It is, which means to fight it, we need a map of the battlefield. We need to understand the body's own pressure control network. And that brings us to our next slide.
Okay, mapping the battlefield. How does the body normally regulate blood pressure, and where are the weak points we can target with drugs?
You can think of it as 4 major control centers. And the key is that they all talk to each other. So if you only target one, the others might compensate and keep the pressure high.
Let's start at the top with the central command, the brain.
Specifically, a region in the brainstem called the vasomotor center. Its job is to regulate what we call sympathetic outflow. This is your fight-or-flight system.
Adrenaline.
Adrenaline, norepinephrine, all the stress hormones. When the sympathetic system is activated, your heart races and your blood vessels clamp down. Our centrally acting agents are designed to go right to the source and tell the brain to turn down that stress signal.
Okay, so control center 1 is the brain. What's number 2?
The heart itself, the pump. How fast and how hard it pumps determines your cardiac output. If the pump is working overtime, pressure goes up. Simple as that.
And that's the prime target for one of the most famous classes of drugs.
Beta blockers, exactly.
Yes.
They work on the beta-1 receptors in the heart to basically tell it to slow down and pump with less force.
Okay, so brain, heart. What's third?
The blood vessels, the pipes. How tight or relaxed those pipes are determines the peripheral vascular resistance, or PVR.
Right. Tighter pipes, higher resistance, higher pressure.
Precisely. And this is where we launch a direct assault with several drug classes. Alpha blockers, calcium channel blockers, and other vasodilators. They all have one mission: tell the pipes to relax.
And that brings us to the fourth, and according to our source material, the most critical control center, the kidneys.
The kidneys are the strategic linchpin of this entire system. They manage your body's salt and water balance, which controls your blood volume. But more importantly, they are the headquarters for a hormonal cascade called the renin-angiotensin-aldosterone system, the RAAS system.
This RAAS system seems to be a huge focus. Why is it so important?
Because it's the body's most powerful, long-term survival mechanism for raising blood pressure. It's designed for emergencies, like massive blood loss. The problem in hypertension is that this emergency system gets stuck in the on position.
Okay, let's walk through this pathway step by step because it looks like half our drugs target it. Where does it start?
It starts when the kidney senses low blood flow or gets a stress signal from the sympathetic nervous system. In response, it releases an enzyme called renin into the bloodstream.
Renin is the trigger.
Renin is the trigger. It finds a protein made by the liver called angiotensinogen and clips it, turning it into a molecule called angiotensin I.
So angiotensin A is step 2. Is that the active molecule?
Not yet. Angiotensin A is mostly inactive. It's like a preloaded weapon waiting for the final command. That command comes from another enzyme, mainly found in the lungs, called ACE, angiotensin-converting enzyme.
And ACE does exactly what its name suggests.
It converts angiotensin A into the main villain of our story, angiotensin II.
Okay, so angiotensin II is the bad guy. What does it do that's so terrible?
2 major things, and it does them with brutal efficiency. First, it is the most potent natural vasoconstrictor in the human body. It immediately clamps down on blood vessels everywhere, which skyrockets peripheral vascular resistance.
So it squeezes the pipe shut. What's the second action?
It travels to the adrenal glands, which sit on top of your kidneys, and tells them to release another hormone called aldosterone.
And aldosterone's job is?
Salt and water retention. Aldosterone's message to the kidneys is, hold on to every last molecule of sodium and water you can. This increases the total volume of blood in your system.
Wow. So angiotensin II attacks from both sides. It increases resistance by tightening the vessels, and it increases pressure by adding more fluid to the system.
It's a master regulator, and understanding that cascade gives us 3 beautiful, high-value targets for our drugs. We can block renin at the start, we can block ACE in the middle, or we can block angiotensin II at the end.
This makes perfect sense. This is the foundation for our entire arsenal.
All right, let's move to the next slide and meet the first units in that arsenal, the RAAS blockers. First up, the production saboteurs.
The ACE inhibitors, their mission is elegant and direct.
Yeah.
Stop the production of angiotensin II. They do this by blocking that key enzyme, ACE.
So no AC, no conversion of angiotensin I to angiotensin II.
Exactly. And the result is you get less vasoconstriction, so the vessels relax, and you get less aldosterone release, so the kidneys get rid of more salt and water. You're tackling both resistance and volume. It's a very powerful mechanism.
And the agent roster here is one of the most common groups of DIGAs out there. The Laprils, captopril, enalapril, lisinopril.
Ramipril, if it ends in opril, it's an ACE inhibitor. The mnemonic our source gives is pretty good. Think of April Fools, because you're fooling the ACE enzyme into not doing its job.
Ah, I like that.
Mm-hmm.
But these are powerful drugs, and with great power comes, well, a long list of potential adverse effects. The material gives us a great mnemonic for this, captopril.
Yes, and we need to go through this carefully. Let's start with C. That stands for cough.
This is the famous ACE inhibitor cough, right? I've heard about this. It's a dry, hacking cough.
It's the #1 reason people stop taking these drugs. And the mechanism is fascinating. It turns out that the ACE enzyme doesn't just create angiotensin II. It also has another job, breaking down a substance called bradykinin.
So when we block ACE to stop angiotensin II,
We inadvertently cause a buildup of bradykinin, especially in the lungs. And bradykinin is an inflammatory substance that can trigger the cough reflex. It's a direct, unavoidable consequence of the mechanism.
okay, so C is for cough. What's A?
A is for angioedema. This is much rarer than the cough, but far more dangerous. It's a rapid swelling of the lips, tongue, and throat, which can block the airway. It's a medical emergency.
Is that also caused by bradykinin?
We think so, yes. The same mechanism. And if a patient develops angioedema on an ACE inhibitor, they can never, ever take another drug from that class again.
Okay, KEPT-OPP is proteinuria.
T is the big one, the highest alert. T stands for terogenic. ACE inhibitors are absolutely 100% contraindicated in pregnancy.
Why is that? What do they do to the fetus?
They can cause severe developmental problems, especially with the fetal kidneys, leading to renal failure, low amniotic fluid, and even death. This is non-negotiable. No ACE inhibitors during pregnancy.
Got it. Okay, O in captopril.
O is for the opposite of high BP, which is hypotension, especially after the first dose. You can get a big drop in pressure, so we always start with a low dose.
Makes sense. R is for rashes. And then we have K, or in this case I see it's K for kalium.
Right. Kalium is the Latin name for potassium. K stands for hyperkalemia, or high potassium levels. Remember how angiotensin II leads to aldosterone? And aldosterone makes you excrete potassium?
Yes.
Well, when you block that system, you stop excreting potassium, so your body holds on to it. This can be dangerous, especially for patients who already have kidney problems.
And the L at the end is loss of taste. Dysgeusia. Wow, that's a comprehensive list.
It is. And there's one more critical contraindication we have to mention. Bilateral renal artery stenosis.
That's when the arteries leading to both kidneys are narrowed, right?
Correct. In that specific situation, the kidneys become completely dependent on the powerful vasoconstricting effect of angiotensin II just to maintain enough pressure to filter blood. If you take that away with an ACE inhibitor, you can cause sudden, irreversible kidney failure. It's a classic trap.
Okay, so the paprils are powerful, but they have some very specific risks. What if patient gets that POF? Are there other options to block the RAA system? And that brings us to the next slide.
Yes, there's an elegant workaround. Unit 2, the receptor jammers and source blockers. Let's start with the angiotensin receptor blockers, or ARBs.
So instead of stopping the production of angiotensin II, these drugs stop its action.
Exactly, they are receptor jammers. Angiotensin II is still floating around in the bloodstream, but when it gets to the blood vessels, it finds the ARB molecule is already sitting in its parking spot, the AT1 receptor. It can't bind, so it can't cause vasoconstriction.
It's a competitive blockade.
A perfect competitive antagonism. And the agent roster here is just as easy to recognize. Sartans, losartan, valsartan, candesartan.
Telmisartan. The mnemonic here is to think of a relaxing sultan who blocks angiotensin.
A bit of a stretch, but it works. And their strategic advantage is huge. They give you all the blood pressure lowering benefits of blocking the RAAS system.
But because they don't touch the ACE enzyme, they don't affect bradykinin.
And that's the key. No bradykinin buildup means significantly less cough and a much lower risk of angioedema. This makes the ARBs the automatic go-to drug if a patient on an ACE inhibitor develops that cough.
It's a perfect solution. Now, this slide also mentions a third type of RAAS blocker, the direct renin inhibitor.
Right. There's really only one agent in this class that we use, eliskerin.
And its mission is to go all the way back to the beginning of the cascade.
To the absolute source. It directly inhibits the enzyme renin, so you never even convert angiotensinogen to angiotensin I. The whole cascade is stopped before it even begins.
That sounds like the most logical approach of all. Why isn't it the first-line drug for everyone?
You know, it's a good drug, but it hasn't shown superior outcomes compared to the ACEs and ARBs, which have decades of data behind them. Its main role right now is often as an add-on therapy if someone needs a little extra RAAS blockade.
Okay, but one thing is critical here. Even though they work differently, do all three of these classes, ACEs, ARBs, and DRIs, share the same big warnings?
They do. They all carry the risk of hyperkalemia, hypotassium, and all three are absolutely teratogenic and must be stopped before or during pregnancy. You cannot block the RAAS system in a developing fetus.
That's a crucial takeaway. Okay, we've thoroughly covered how to sabotage the RAAS system. Now let's move on to the next slide and look at some different tactics. Controlling fluid and directly relaxing the vessels.
Right. Coming to the next slide, Unit 3. The fluid control unit, the diuretics.
The mission here seems pretty simple. Drain the pipes.
That's the perfect way to put it. Their job is to reduce blood volume by making the kidneys excrete more sodium and water. You pee out the excess fluid, and with less volume in the system, the pressure naturally drops.
The source material focuses on two main types. The first and most common are the thiazides.
Yes, drugs like hydrochlorothiazide or HCTZ and chlorthalidone. These are the absolute workhorses for uncomplicated hypertension. They're effective, they last a long time, and they're inexpensive. They've been a cornerstone of treatment for decades.
How do they work? Where in the kidney do they act?
They target a specific part of the kidney tubule called the distal convoluted tubule, or DCT. There's a little pump there, a symporter, that reabsorbs sodium and chloride back into the body. Thiazides block that pump.
So the sodium and chloride stay in the urine.
And water always follows salt, so the water stays in the urine too, and you excrete more fluid.
Okay, and the second type mentioned are the loop diuretics.
Right, like furosemide.
Yeah.
These are the heavy hitters. They work earlier in the kidney, in the loop of Henle, and they are much, much more powerful than thiazides.
So they're not for standard hypertension.
Generally not. We reserve them for situations where there's massive fluid overload, like in patients with severe congestive heart failure or kidney failure. For regular hypertension, they're usually overkill.
Let's focus on the thiazides then. What's the field report on their adverse effects? They seem to mess with a lot of electrolytes.
They do. The biggest one to watch is K-down, or hypokalemia low potassium. The way the kidney adjusts to the thiazides effect causes it to waste a lot of potassium. This is a very common side effect.
And it also mentions some metabolic issues.
Yes, 3 hypers. Hyperglycemia, so it can raise blood sugar. Hyperlipidemia, it can raise cholesterol and triglycerides. And hyperuricemia, it can raise uric acid levels and potentially trigger a gout attack.
So you'd have to be careful using these in a patient with diabetes or gout.
Absolutely. But then there's one really interesting counterintuitive effect. Thiazides cause CAS-up, or hypercalcemia.
So they make you lose potassium but hold on to calcium.
Exactly. Unlike most other diuretics, they decrease the amount of calcium you excrete. For some patients, like an older woman at risk for osteoporosis, this can actually be a beneficial side effect. You're treating her blood pressure and helping her bones at the same time.
That's fascinating. Okay, so we've drained the fluid. Now let's move to our next slide and Unit 4. The ones that directly relax the pipes themselves. The gate blockers.
The calcium channel blockers, or CCBs, Their mission is to block the entry of calcium into the smooth muscle cells that line your arteries.
And calcium is the trigger for muscle contraction, right?
Right. It is. Calcium rushes into the cell and the muscle squeezes. So if you block the calcium channel, specifically the L-type channel, the signal to contract is blocked. The muscle relaxes, the vessel dilates, and the blood pressure drops. It's a very direct mechanical approach.
The source material divides these into two very distinct subclasses. First, the dihydropyridines, the ditapines.
Amlodipine, nifedipine, felodipine, these are your pure vasodilators. Their primary effect is on the blood vessels, with very little effect on the heart itself.
The mnemonic is pretty memorable. You dip into a relaxing bath to lower your tension.
I like it. And because they're such potent vasodilators, their side effects are exactly what you'd expect, all related to rapidly widening blood vessels.
So things like headache, flushing.
Ankle edema or swelling, that's a big one. People often worry it's heart failure, but it's usually just fluid pooling in the dilated vessels of the lower legs. And the other key side effect is reflex tachycardia. When you drop the blood pressure so suddenly, the body's baroreceptors panic and send a fight-or-flight signal to the heart, telling it to speed up to compensate so you can get a racing heartbeat.
Okay, so those are the dihydropyridines, the pure vasodilators. What's the other subclass?
The non-dihydropyridines, or non-DHPs. The two main agents are verapamil and diltiazem.
And they are different because they affect the heart.
Very much so. They are also vasodilators, but they have a significant additional effect of directly depressing cardiac function. They slow the heart rate down and reduce the force of its contraction.
So they have a dual action.
They do, which makes them great for some conditions, like controlling a rapid heart rate, but potentially dangerous in others, which we'll get into in the strategy section. Overall, though, the CCBs are a fantastic class, especially useful in elderly patients and, crucially, in patients with asthma.
Why asthma specifically?
Because their mechanism has nothing to do with the beta receptors in the lungs, so there's no risk of causing bronchospasm. And that's the perfect lead-in to our next slide and our fifth unit of the arsenal.
Now coming to the next slide, Unit 5, the sympathetic override. The beta blockers.
Yes, these are our systemic dampeners. Their mission is to block the effects of the sympathetic nervous system, that fight-or-flight response, at its key targets.
And they do this in a few different ways, right? It's not just one mechanism.
Correct. First and foremost, they block beta-1 receptors in the heart, which directly reduces heart rate and cardiac output. They slow the pump down. Second, they block beta-1 receptors in the kidney, which disrupts the release of RAN.
So they're indirectly blocking the RAA system as well.
They are. It's a secondary effect. And third, they have some effects in the brain that decrease overall sympathetic outflow. It's a multi-pronged attack on the stress response.
The agent roster is another easy one to spot. The OLOLs, atenolol, metoprolol, propranolol.
The mnemonic is that beta blockers make your heart rate go lower. It's a bit silly, but it sticks.
It does. Now, the key distinction here seems to be selectivity. Cardioselective versus non-selective.
This is absolutely critical. The cardioselective agents, like atenolol and metoprolol, primarily target the beta-1 receptors, which are mostly found in the heart. This makes them much safer for patients who have lung problems.
Because the lungs have beta-2 receptors.
Exactly. And the non-selective agents, like propranolol, block both beta-1 and beta-2 receptors. If you block beta-2 receptors in the lungs of someone with asthma, you can cause life-threatening bronchoconstriction.
So you have to choose your agent very carefully. Who are these drugs ideal for?
Their ideal mission profile is in younger hypertensive patients who often have that high sympathetic drive type of hypertension. And they are absolutely essential for patients who also have angina or have had a heart attack.
Why is that?
By slowing the heart down, they drastically reduce the heart muscle's demand for oxygen. This protects the heart from ischemia and has been proven to improve survival after a heart attack.
But they're not without their downsides. The source mentions some collateral damage that affects compliance.
Yeah, they're famous for it. Fatigue is very common. Cold hands and feet. And significantly, they can cause sexual dysfunction, which is a major reason why some patients stop taking them.
And there's some very high alert cautions here. We've mentioned avoiding non-selectives in asthma. What else?
You have to be very cautious when using them in patients with diabetes. The sympathetic response, a fast heart rate, tremors, is the body's main warning sign of low blood sugar or hypoglycemia. Beta blockers can block and mask those warning signs.
So a diabetic patient could be dangerously hypoglycemic and not even realize it.
It's a huge risk. And the third, absolutely critical warning. You must never, ever stop a beta blocker abruptly.
Why not?
Because when you block the receptors for a long time, the body compensates by making more of them, it upregulates them. If you suddenly withdraw the drug, all those extra hypersensitive receptors are exposed to your natural adrenaline. This can cause a severe withdrawal syndrome with rebound hypertension, tachycardia, and even a heart attack. You must always taper the dose down slowly.
That is crucial safety intel. Okay, let's go to our next slide and look at some of the key supporting units in our arsenal. These are more for special situations.
Exactly. Coming to the next slide, let's start with the alpha-adrenergic blockers. The FASINs.
Prazosin, doxazosin. Their mechanism is pretty straightforward, right? They block alpha-1 receptors on blood vessels, causing vasodilation.
It is. They aren't usually a first-line choice for just hypertension, but they have a fantastic strategic niche.
And that niche is men who also have benign prostatic hyperplasia, or BPH.
That's the one. The alpha-1 receptors are not only on blood vessels, they're also on the smooth muscle of the prostate and bladder neck. So an alpha blocker relaxes both, treating the high blood pressure and, at the same time, improving the urinary symptoms of BPH. It's a 2-for-1 deal.
But there's a big warning sign here. The first dose phenomenon.
Yes. Because they are potent vasodilators, that first dose can cause a massive drop in blood pressure when the patient stands up, leading to dizziness or even fainting. We call it postural hypotension.
So what's the standard procedure to avoid that?
Always start with a very low dose and instruct the patient to take that first dose right at bedtime so they're already lying down when the drug kicks in.
Smart. Okay, who's next in the support team?
The centrally acting sympatholytics. The main agents are clonidine and methyldopa.
These are the ones that work directly in the brainstem.
They do. They stimulate central alpha-2 receptors, which acts like a master off switch for the entire sympathetic nervous system. They just tell the brain to calm down and send out fewer stress signals.
And methyldopa has one of the most important strategic roles we've talked about.
It does. Methyldopa is one of the preferred, safest agents for managing hypertension during pregnancy. It has a long track record of safety for the fetus.
But they're not used as often anymore for general hypertension, right? Why is that?
A high incidence of side effects. Because they work centrally, they can cause significant sedation, dry mouth, and brain fog. And clonidine, just like the beta blockers, carries a very high risk of severe rebound hypertension if you stop it suddenly.
Okay, and our last group is supporting units.
Yeah.
The big guns.
The direct vasodilators. Hydralazine and minoxidil. Their mechanism is brute force. They just directly relax the smooth muscle of the arteries.
And they're niches for the toughest cases.
Resistant hypertension. This is for the patient who is already on 3 or 4 other drugs, including a diuretic, and their blood pressure is still dangerously high. These are the agents you bring in when nothing else is working.
But because they are so incredibly powerful, they trigger a huge compensatory response from the body.
A massive one. You get profound reflex tachycardia and significant fluid retention. The body fights back hard. For this reason, you almost never prescribe them alone. They are always given as part of a team.
So you give hydralazine along with a beta blocker to control the heart rate.
And a diuretic to get rid of the retained fluid. You have to anticipate and block the body's response.
That's a masterclass on the entire arsenal. Now this is where it gets really interesting. Let's move to the next slide and talk about advanced strategy. Matching the right unit to the right mission.
This is the most important part. The core principle here is that the best drug doesn't just lower a number. It benefits, or at least doesn't harm, the patient's other medical conditions. We're tailoring the tactic.
Let's run through this comorbidity checklist. First up, a patient with diabetes or diabetic nephropathy.
The recommended first-line agents here are, without a doubt, the ACE inhibitors or the ARBs. And it's not just for the blood pressure. They are uniquely kidney protective.
How do they protect the kidney?
They preferentially dilate the efferent arteriole, the vessel leaving the kidney's filter, which lowers the pressure inside the delicate filtering unit. This has been shown to slow down the progression of diabetic kidney disease. It's a 2-for-1 benefit.
Fantastic. Okay, next profile. A patient with angina or who has had a heart attack.
Here, beta blockers are mandatory first-line agents, along with an ACE inhibitor or an ARB. The beta blocker is critical for reducing the oxygen demand of the damaged heart muscle. It's a cardioprotective strategy.
What about congestive heart failure, where the pump itself is weak?
The pillars of therapy are ACE inhibitors, or ARBs, combined with diuretics. The RAAS blockers prevent harmful remodeling of the failing heart, and the diuretics are essential for managing the fluid overload that comes with CHF.
And is there a class we absolutely must avoid here?
Yes. The non-DHP calcium channel blockers, verapamil and diltiazem,
Hmm.
because they suppress cardiac function, giving them to a heart that's already failing can make the CHF much, much worse.
That's a critical distinction. Okay, let's switch to a patient with a respiratory issue like asthma or COPD.
The main goal is to avoid bronchospasm. So the recommended first-line agents are the calcium channel blockers, as they are completely safe for the lungs.
And the class to avoid at all costs.
The non-selective beta blockers, like propranolol, the risk of triggering a severe asthma attack is just too high.
Next up, the tactical synergy we mentioned earlier, a male patient with BPH.
The perfect choice is an alpha blocker, like prazosin or doxazocin. It treats both conditions with a single pill.
And finally, the highest stakes scenario, pregnancy.
Safety of the fetus is the only priority. The recommended agents with a long safety record are labetalol, which is a beta blocker, methyldopa, and nifedipine, a CCB. And we must say it again, absolutely avoid all ACE inhibitors and ARBs. They are teratogenic.
This checklist is a perfect illustration of why this is such a strategic discipline. But what happens when things go completely off the rails? Now, coming to our next slide, the crisis protocol.
Yes, responding to a hypertensive emergency. The first, most critical step is to distinguish between an emergency and an urgency.
The numbers are the same for both, right? A systolic over 180 or a diastolic over 120, so what's the difference?
The difference is end organ damage. If the patient has those numbers and is showing signs of acute ongoing damage, like they're confused or having chest pain, or their kidney function is plummeting, that is a hypertensive emergency. It requires immediate IV treatment in a hospital.
And if they have the same numbers but feel relatively fine, maybe just a headache.
That's a hypertensive urgency. There's no acute organ damage. We have time. We can manage that with oral medications over hours or even a couple of days. The presence of organ damage dictates the entire pace and setting of the treatment.
Okay, and this leads to the golden rule of managing these crises, which seems so counterintuitive at first. Do not normalize the blood pressure rapidly. Why not?
It's all about cerebral autoregulation. If a person has been living with a blood pressure of 220 over 130 for months or years, their brain has adapted. The blood vessels in their brain have constricted to protect themselves from that extreme pressure.
So they're used to that high-pressure environment.
They are. If you use a powerful IV drug and drop their pressure to 120 over 80 in 10 minutes, those constricted vessels can't dilate fast enough. The blood flow to the brain can drop precipitously.
You could cause a stroke by treating the blood pressure too aggressively.
Precisely. You can induce organ ischemia. So the goal is a controlled, gradual reduction. The rule of thumb is to reduce the mean arterial pressure by no more than 25% within the first hour. Then bring it down slowly to a safer level, like 160 over 100, over the next 2 to 6 hours.
A controlled descent. And to do that, you need a specialized arsenal of IV agents.
You do. These are drugs that can be titrated minute by minute. We use things like sodium nitroprusside, a very potent vasodilator, nicardipine, an IV CCB, and labetalol, the combined alpha and beta blocker, which is great because it lowers pressure without causing a big reflex tachycardia. The choice depends on the specific type of organ damage we're seeing.
This is truly advanced strategy. We've covered the individual units and the crisis response. Let's finish with our last few slides on how to combine these forces for maximum long-term impact.
Right, coming to the next slide. For most patients, one drug isn't enough. The rationale for combination therapy is to attack the problem from multiple angles, which often gives a better result with fewer side effects.
But just as important as knowing what to combine is knowing what not to combine. Let's start with the red flags, the combinations to avoid.
Red flag number 1, an ACE inhibitor plus an ARB.
This seems to come up a lot. Why is it so bad? You're blocking the same pathway in two different places.
And that's the problem. It's redundant. You get almost no additional blood pressure lowering benefit, but you dramatically increase the risk of the bad stuff, severe hyperkalemia and acute kidney failure. The rule is simple. Never double block the RAAS pathway.
Okay, one RAS blocker at a time. What's the second big red flag combination?
A beta blocker plus a non-DHP calcium channel blocker, like verapamil or diltiazem.
Why is that a dangerous pair?
Because both agents strongly suppress the heart. They both slow the heart rate and decrease contractility. If you use them together, you have an additive effect that can lead to severe bradycardia, a dangerously slow heart rate, or even complete heart block. It's a very risky combination.
Good to know. Now let's look at the green lights, the highly effective synergistic combinations.
The most common and most effective is an ACE inhibitor or an ARB plus a thiazide diuretic. This is a brilliant combination.
Why does it work so well?
Two reasons. First, they have synergistic effects on blood pressure. The diuretic lowers volume, which activates the RAAS system, and the RAAS blocker is there to block that activation. Second, they counteract each other's side effects. The thiazide makes you lose potassium, and the RAAS blocker makes you retain potassium. They balance each other out perfectly.
It's elegant. What's the other major green light combo?
An ACE inhibitor or an ARB plus a dihydropyridine calcium channel blocker like amlodipine. This is another powerhouse combination. You're targeting two completely different mechanisms: the hormonal RAS system and the mechanical stiffness of the blood vessels. This dual-pronged attack is highly effective.
Okay, we have covered an incredible amount of intel. Let's go to our next slide and run a quick field test, a little Q&A, to solidify this knowledge.
Sounds good.
Question 1. A patient is started on lisinopril and develops that classic, persistent, dry cough. What's the mechanism, and what is the logical next step?
The cough is caused by the buildup of bradykinin because lisinopril, an ACE inhibitor, blocks the enzyme that normally breaks it down. The logical next step is to switch the patient to an ARB, like losartan. It provides the same RAAS blockade benefits but doesn't affect bradykinin, so the cough will go away.
Perfect. Question 2. You need to start an antihypertensive in an older male patient with a history of both asthma and BPH. Which drug class is an excellent choice that treats both, and which class must be avoided?
The excellent choice is an alpha blocker, like doxazosin. It will lower his blood pressure and also help his urinary symptoms from BPH. The class that must be absolutely avoided is a non-selective beta blocker, like propranolol, because the high risk of causing a severe bronchospasm due to his asthma.
Nailed it. Last one. Question 3. Why is a drug like methyldopa considered safe and preferred in pregnancy, while an ACE inhibitor like ramipril is strictly contraindicated?
Methyldopa has a long-established safety record in pregnancy. ACE inhibitors, on the other hand, are known teratogens. They can interfere with fetal kidney development, causing hypotension, renal failure, and even death in the fetus. The risk is unacceptably high.
Fantastic. That really brings it all together. Let's move to our final slide for the commander's takeaway.
Yes. Let's summarize this entire briefing into 4 key pillars.
Pillar 1. Know the battlefield. This means mastering the roles of the sympathetic nervous system and, most importantly, the RAAS pathway. These are the primary targets.
Pillar 2. Master your arsenal. You have to know the core mechanism of each major drug class. Know the paprils, the sartans, the fatipines, the olols. Know how they fight.
Pillar 3. Tailor the tactic. This is probably the most important. Always select your agent based on the patient's comorbidities. The right drug for one person can be dangerous for another.
And Pillar 4. Combine forces wisely. Use logical, synergistic combinations and avoid the dangerous pairings we discussed. This is what transforms treatment from guesswork into a calculated, effective strategy.
The big takeaway here is that managing hypertension isn't just about lowering a number. It's a complex, long-term strategic campaign to protect vital organs and, ultimately, to save lives.
It really is. And, it brings up a final provocative thought. Our source material makes it clear that for primary hypertension, there's no single cause.
Right. It's a multi-system failure. So, what happens when you have a patient where it's not just one system that's out of whack? What if their sympathetic nervous system is in overdrive and their RAS system is hyperactive and their vessels are already stiff and non-compliant?
That's the reality for many patients. You're not fixing one broken part, you're trying to manage a complete network failure. And that complexity is precisely why we need to master all these different drug classes and, more importantly, why those intelligent multi-drug combination strategies are not just an option but an absolute necessity. It reminds us that every single patient is a unique strategic puzzle.
A fantastic way to wrap up this incredibly detailed briefing.
Welcome back to the deep dive. Today we are strapping into the cardiac crash cart, but instead of focusing on the emergency maneuvers, we are going deep into the logic, the chemistry, and the high-stakes pharmacology that saves the heart.
That's right. Our mission is critical. We need to understand that delicate balance that keeps the heart healthy, the exact moment that balance fails, and then the life-saving drugs we use to restore it.
We're moving beyond just, recognizing chest pain. We're going to be opening up the cardiac drug cabinet, really examining the tools inside and understanding why each tool works.
And what precise molecular mechanism it's using to stabilize a heart that's under duress. This is essential knowledge for anyone looking to truly get a handle on heart health.
Exactly. It's about the logical reasoning behind common prescriptions and that chemical race against time that happens during a cardiac emergency.
It is a race.
We are diving deep into angina pectoris, that sensation of crushing chest pain and its life-threatening
It's a complex cascade of events, but our goal today is to take that immense complexity and just distill it down into actionable, logical nuggets.
focusing on the drugs for both chronic management and the acute crisis, their mechanisms, and of course the critical safety warnings. I think understanding the logic here is really empowering for you, the listener.
It is. It's a study in chemical precision. We're going to examine how just slight changes in molecular structure can rapidly shift the entire physiological state of a person, taking them from crisis to, hopefully, stability.
Okay, let's unpack this and jump right into the foundation of the problem. Now, coming to our first slide, we have to grasp the fundamental physics of this whole crisis.
We do.
So on this slide, we're calling it the battle for the heart, an oxygen story. I think the best way to visualize this concept is as a classic set of scales, or a seesaw.
That's a perfect analogy. It illustrates the core concept of cardiac pain. Angina pectoris, that chest tightness, it isn't the final disease. It's a symptom.
And a very specific one.
A very specific one. Clinically, we define it perfectly. It is the heart's urgent cry for oxygen.
That's the core tension, right? The heart muscle, the myocardium, it requires this immense, constant supply of oxygen to do its job.
It never rests. It just slows down. So angina only occurs when that scale is unbalanced, when the oxygen demand of the heart muscle outweighs the oxygen supply that's being delivered.
Okay, let's look at the demand side first, the heart's workload. If that demand goes up, the heart is basically asking for more fuel than its pipes can deliver. What exactly drives up that demand?
We can break the cardiac workload down into three primary mechanical factors. And if you target these three with drugs, you successfully reduce that demand.
Okay.
First, and most intuitively, is an increased heart rate. If the heart is beating faster, say from exertion or stress or even caffeine, it spends less time in diastole.
Which is the resting phase.
The resting phase, exactly. It's the phase where the coronary arteries are actually perfused or filled. So less rest means higher fuel consumption. It's that simple.
So we need drugs that can slow that rate down. What's the second factor?
The second is increased ventricular contractility. This is the literal force at the pump. How hard the ventricular muscles are squeezing to eject blood.
Like an adrenaline surge.
A perfect example, adrenaline surges dramatically increase contractility. And the stronger that squeeze, the greater the metabolic demand, the higher the oxygen consumption.
And the third factor, this one's a bit more architectural, right? Relates to the heart itself.
It does. It's increased ventricular wall tension. This is tied very closely to the pressure inside the ventricle. Think of the law of Laplace. The pressure inside a sphere is related to the tension in its wall and the radius of that sphere.
So more stretch equals more tension.
Exactly. When the ventricular walls are stretched or when the pressure is high, the muscle has to generate immense tension to overcome that pressure and eject the blood. This requires a disproportionately high amount of oxygen. So if you can reduce the stretch, which we call preload, or the opposing pressure, which we call afterload, you reduce wall tension.
So a sprinter's heart working fast, contracting hard, generating high tension is just dramatically cranking up its oxygen demand.
Massively.
Now let's look at the other side of the scale. Oxygen supply, the fuel line itself. This is the blood flow delivered by the coronary arteries. What chokes off this supply?
The causes here fall into two main categories. You have chronic structural narrowing, and then you have acute sudden blockage.
Let's start with the chronic one.
The most common chronic issue is coronary atherosclerosis. This is plaque buildup, cholesterol, fats, cellular debris inside the artery walls. It just narrows the pipe, the lumen, and restricts flow gradually over time.
And the acute problems.
There are two. One is coronary vasospasm. This is a sudden, involuntary, intense tightening of the artery wall. It can be due to a dysfunctional endothelial lining or chemical irritants. It's like someone just put a sudden clamp on the pipe.
And the final, worst case scenario.
That's coronary thrombosis. This is where a blood clot, often triggered when an unstable plaque ruptures, completely blocks the artery. This leads to an acute, severe deficiency. In other words, an MI, a heart attack.
So if the demand goes up, you climb a steep hill, And the supply is already restricted by plaque, the scale tips, the heart cries out, and that cry is angina.
Precisely. And every single drug we're about to discuss operates by strategically pushing that seesaw back into balance.
Okay, now coming to the next slide. Understanding the battle is key, but the symptoms themselves give us major clues about how severe the crisis really is. Let's look at the warning signs. Understanding angina's 3 phases.
This clinical distinction is absolutely vital because the type of angina dictates the urgency and the choice of medication. We have stable angina, unstable angina, and then prinzmetal angina.
Let's start with the classic case, stable classical angina.
Stable angina is the predictable warning signal.
Yeah.
It's characterized by episodes of chest pain that are linked strictly to exertion or maybe emotional stress. The key is that the pain is consistent and critically it's reproducible.
Can you give us an example?
Sure. A 65-year-old feels that classic tightness every single time they walk up a flight of stairs, but it consistently goes away with rest or a quick-acting medication. That's stable angina.
And the reason it goes away with rest is pretty straightforward, right? By resting, the patient immediately lowers their heart rate and contractility.
They successfully cut the oxygen demand. The restricted supply line, which is narrowed by that stable plaque, it couldn't keep up during the exertion, but it can maintain adequate flow when the person is just sitting there. It's a manageable demand mismatch.
Now, contrast that with unstable angina. This is where the story shifts into a true emergency.
It is. Unstable angina signals imminent danger. It's defined as angina that occurs at rest, or a sudden drastic increase in the frequency, duration, or severity of the attacks compared to what's normal for that person.
What does it tell the clinician?
It tells them that the plaque has become highly volatile. The underlying pathology here is usually a plaque rupture with subsequent platelet deposition and thrombus formation. A partial clot is now severely restricting flow, even when the patient is completely inactive and their demand is low.
And because a fully occlusive clot could be just minutes away.
Unstable angina is treated as an immediate high-risk event. It signals the potential onset of a full heart attack.
And then we have the outlier, the one that kind of breaks the rules of demand, prinzmetal variant angina.
Prinzmetal angina is the odd one out because it's primarily a supply problem. It's a failure of the coronary arteries to stay open rather than a demand problem.
And it also happens at rest.
Typically at rest, often in the early morning hours. And it's caused by a sudden, intense focal spasm of the coronary arteries, that acute clamp we just talked about.
So in prinzmetal, the heart isn't asking for more oxygen. The pipe just suddenly closes down on its own.
Precisely. And this distinction is clinically paramount. While reducing demand is the goal for stable angina, using drugs that only reduce demand might fail, or in certain cases, even worsen a supply-side problem like prinzmetal angina.
And that's going to be really important when we talk about beta blockers later on.
Incredibly important.
Okay, that sets the stage. We've established the supply-demand scale and the 3 phases of cardiac pain. Now we can pivot to the chronic drug management regimen, aiming to keep that scale balanced in the long term for stable patients.
Let's do it.
Now, with that foundation set, let's look at the solutions. If we need to stabilize the heart long term, what's the first tool we reach for to rapidly cut the workload? Now, coming to our next slide, we'll start with nitrates, the rapid responders.
They really are the cornerstone of rapid relief, and their primary mission is simple in concept. They decrease the heart's preload.
Preload is such a fundamental concept. We have to be really clear on this for everyone listening.
Absolutely. It's the stretch on the ventricular muscle fibers just before they contract. The analogy I always use is stretching a rubber band. The farther you stretch it, that's high preload, the more potential energy it holds, and the harder it's going to snap back. That's a stronger contraction.
So if the heart is already struggling for oxygen, we want to make that contraction easier. We want to reduce the stretch on that rubber band.
You got it. Less stretch means a less powerful, less forceful contraction, which requires less work and therefore consumes significantly less oxygen.
And how do nitrates achieve this? You mentioned venodilation.
Through venodilation. Nitrates are primarily venodilators. They cause the smooth muscle walls of the veins to relax profoundly. When the veins relax, they become these larger, more compliant reservoirs.
So the blood just pools there.
It pools peripherally in the body's circulation. This pooling dramatically reduces the amount of blood returning to the heart, the venous return. Less venous return means less ventricular filling, which means less stretch or reduced preload.
And reduced preload translates directly to reduced ventricular wall tension.
Which, as we established, is a major factor in reducing overall cardiac work and oxygen demand. It's a direct line.
Let's trace the chemical pathway, because this is where the rapid, profound response comes from. It's a really elegant molecular cascade.
It is. So the journey starts when the nitrate drug, let's say a sublingual tablet, is absorbed. It then enters the vascular smooth muscle cell. And there, the nitrate has to first be denatrated to release the key signaling molecule, nitric oxide, NO.
Nitric oxide, so that's the signal.
That's the signal. NO is a highly potent, very short-acting vasodilator that our bodies make naturally.
And what does that NO signal? What does it do next?
The NO doesn't act alone. It stimulates an intracellular enzyme called guanylyl cyclase. This enzyme then ramps up production of a secondary messenger molecule called cyclic guanosine monophosphate, or CGMP.
CGMP.
And high levels of CGMP are the chemical signal that triggers the final critical step, the relaxation of that vascular smooth muscle.
How does CGMP actually cause the relaxation?
Okay, this is the deep dive nugget. Increased CGMP levels lead to the dephosphorylation of something called the myosin light chain. Myosin light chain phosphorylation is required for the actin and myosin filaments to interact and cause a contraction.
So it's like the on switch for muscle contraction.
It is. And CGMP activates enzymes that flip that switch off. Specifically, myosin light chain phosphatase activity increases, and the muscle is forced into a state of relaxation. That sudden, widespread relaxation is the venodilation we observe. It's what rapidly reduces preload and relieves that angina pain within minutes.
That detailed mechanism really explains why they're called the rapid responders. Now let's move to the next slide and talk about putting nitrates to work. From acute attack to prophylaxis, we need to look at the specific drugs here.
We do. And the undisputed champion for acute relief is nitroglycerin, GTN, or glycerol trinitrate. For an acute attack, the fastest and most effective routes are sublingual, a 0.5 milligram tablet, or a lingual spray, which is about 0.4 milligrams.
The onset is incredibly fast, right? Just 2 to 5 minutes. But the duration is purposely short, maybe 10 to 30 minutes.
Exactly, because it's intended as an emergency brake. And here's a really critical piece of patient advice. If you're using the tablet form and the pain is relieved, you should spit out the rest of the tablet.
Why is that?
It prevents unnecessary prolonged systemic absorption, which only increases the risk of side effects like a severe headache or hypotension.
And for long-term prevention or prophylaxis, GTN can be given differently.
Yes, via a 5 to 10 milligram transdermal patch, which provides sustained coverage for up to 24 hours. But GTN isn't the only nitrate on the shelf.
Right, there's the isosorbide group.
Yes, isosorbide dinitrate can be used sublingually for acute attacks. It offers a slightly longer duration of action than GTN, maybe 20 to 60 minutes. Orally, it provides prophylaxis for about 6 to 8 hours.
And then we have the one that's preferred for reliable oral long-term prophylaxis, isosorbide mononitrate. Why is this one the clinical favorite for oral use?
It all comes down to pharmacokinetics and reliability. When you take a drug orally, it passes through the liver first. This is called first-pass metabolism, and it often breaks down a lot of the drug before it even reaches your circulation.
But not this one.
Not this one.
Oh.
Isosorbide mononitrate has high bioavailability and, crucially, minimal first-pass metabolism. This means a predictable dose reliably enters the bloodstream, resulting in stable, longer-lasting effects, around 6 to 10 hours of coverage. That makes it an excellent choice for a fixed prophylactic regimen.
Okay, now let's move to the downsides. Despite their life-saving function, the side effects of nitrates are almost universally experienced, and they all stem directly from that powerful vasodilation.
Exactly. When you cause massive vasodilation, pressure drops, and blood flow shifts, the 4 main adverse effects are, first, the severe headache, often called the nitrate headache.
I've heard this is pretty intense.
It is. It's often throbbing and intense, caused by vasodilation in the meningeal arteries. In some settings, the severity of the headache can almost confirm the patient is responding well to the drug.
A painful confirmation. What about the others?
Second, postural hypotension, that dizziness when you stand up because blood pools in the extremities. Third, facial flushing. And fourth, critically, reflex tachycardia. As soon as the blood pressure drops, the body's baroreceptors sense it, and the sympathetic nervous system tries to compensate by speeding up the heart rate.
And this brings us to our first crucial safety warnings. First, the issue of tolerance.
Yes. Prolonged, continuous exposure to high doses of nitrates quickly leads to pharmacologic tolerance. The effect just diminishes. To prevent this, the dosing regimen requires a mandated nitrate-free interval of 8 to 12 hours daily.
So for patients using the patch, they'd take it off at night.
Exactly. They remove the patch overnight, typically for 10-12 hours, which allows the vascular smooth muscle cells and their enzyme systems to reset so they can respond effectively the next day. Compliance with this is vital.
And the second critical warning, this is a big one. The dangerous do, #1. This combination is potentially lethal.
This is a non-negotiable contraindication. Nitrates must be avoided for 24 to 48 hours after a patient has taken sildenafil, tadalafil, or other PDE5 inhibitors.
The erectile dysfunction drugs.
Correct. And the mechanism is simple and deadly. Both drug classes work on the same molecular pathway, escalating the effect of that CGMP molecule we just discussed.
So nitrates generate NO, which increases CGMP. What do the PDE5 inhibitors do?
PDE5 is the enzyme that normally breaks down CGMP, which limits vasodilation. PDE5 inhibitors drugs like sildenafil block this breakdown enzyme. So you take a nitrate, you flood the system with CGMP. If you then also take a PDE5 inhibitor, you stop the body's ability to clean up that CGMP.
A double whammy.
A deadly one. The result is an uncontrolled, massive, and synergistic accumulation of CGMP, leading to profound refractory hypotension, a complete failure of vascular tone. It can cause severe shock, myocardial infarction due to poor coronary perfusion, and sudden death. It's a safety point that must be checked every single time.
Okay, so if nitrates are about cutting the heart's preload through vasodilation, let's move to the drugs that directly slow the engine itself. So now coming to the next slide, we'll discuss beta blockers, the pace setters.
Their mission is to decrease heart rate and contractility. They are the ultimate managers of the demand side of the scale.
And they're easy to spot, right? The suffix olol.
Yes, the olol drugs. They work by blocking the beta-love receptors located predominantly on the heart muscle and the conduction system. These receptors normally respond to adrenaline, and noradrenaline are stress hormones.
Telling the heart to speed up and pump harder.
Exactly. So by blocking those receptors, you're turning down the heart's response to stress. You're essentially putting the heart on cruise control.
And the outcome is twofold.
Twofold, both resulting in lower oxygen demand. First, a decreased heart rate, which we call negative chronotropy. Slower rate means more time in diastole, which improves coronary filling. Second, a decreased force of contraction, or negative inotropy.
So the overall result is just a massive decrease in cardiac work.
A massive decrease and, consequently, decreased myocardial oxygen consumption. They make the heart much more fuel efficient, especially under stress.
Clinically, they're slow onset, so they're not for acute relief. They're for prophylaxis of exertional angina.
Correct. Preventing the attacks before they start. But their role goes far beyond simple prevention, especially after a heart attack.
Right. Their role in secondary prevention post-MI is non-negotiable.
Absolutely. In patients who have suffered a recent MI, beta blockers significantly decrease long-term mortality. They reduce the size of potential reinfarction and, crucially, suppress life-threatening ventricular arrhythmias. They're continued indefinitely unless there's a strong contraindication.
A true foundational pillar of survival therapy. And our easy mnemonic for everyone is that drugs ending in olol make the heart rate go LOL lower, decreasing the workload.
It's a reliable trick.
Okay, let's move to our next slide, the beta blocker playbook, cautions and combinations. While they're lifesavers, they have very specific caveats.
They do. Because they directly slow the heart, we have to be extremely cautious in patients who already have bradycardia, a slow heart rate, or certain types of heart block.
And what about the lungs?
Some beta blockers, especially the older non-selective ones, can also block beta-2 receptors in the bronchioles of the lungs. Blocking these can induce severe bronchospasm in asthma or COPD patients.
But the critical contraindication is tied directly back to the type of angina we defined earlier. Beta blockers are a major contraindication for Prinzmetal variant angina. Why is that? Why is a drug designed to help the heart actually dangerous in this specific scenario?
This is a test of true pharmacological understanding. The smooth muscle lining the coronary arteries is controlled by the sympathetic nervous system via two receptor types. Beta-2 receptors, which signal vasodilation or opening the pipes.
And alpha-dollar receptors,
which signal vasoconstriction or tightening the pipes. In a healthy state, there's a balance.
So when you give a beta blocker,
when you administer a non-selective or even some cardioselective beta blockers, you risk blocking those vasodilating beta-2 receptors. This action removes the open-up signal, leaving the constricting alpha-1 receptors unopposed.
So the tighten down signal takes over completely?
Completely. The unmitigated alpha-1 activity aggressively signals the vessel to constrict, dramatically worsening the coronary vasospasm that characterizes Prinzmetal angina. It's highly dangerous.
This complexity, though, leads us to what you call a perfect partnership. combining beta blockers and nitrates. They synergize because they manage the heart from different angles and, critically, counteract each other's negative side effects.
This combination is just intelligent polypharmacy. First, remember how nitrates cause that reflex tachycardia?
A fast heart rate in response to low blood pressure?
Right. Beta blockers are perfectly positioned to block this reflex, maintaining a stable low heart rate. Second, beta blockers can sometimes slightly increase LV and diastolic volume, but nitrates mitigate this by aggressively reducing preload. And third, beta blockers carry that risk of spasm. Nitrates, as powerful vasodilators, actively prevent this. They're truly complementary.
We've covered the venous side with nitrates and the heart rate force with beta blockers. Now we tackle the arterial system and contraction mechanism directly. Moving to our next slide, let's talk about calcium channel blockers, the gatekeepers.
They're called the gatekeepers for a fundamental reason. Their mechanism is cellular. CCBs block voltage-sensitive L-type calcium channels. These are present in cardiac muscle cells and smooth muscle cells throughout the vascular system.
And calcium entry is the trigger for contraction, right?
It is the required trigger. So if you block that gate, you prevent contraction, leading to relaxation or slowing of the heart.
And crucially, within the CCB class, we don't just have one type. We have 3 distinct families, each specializing in a different target.
This is the mastery level distinction. First, we have the dihydropyridines, DHPs. These are the vessel specialists. Think of drugs ending in adipine like nifedipine, amlodipine, and felodipine. Their primary action is potent peripheral arteriolar dilation.
And this dilation lowers what we call afterload. Let's just pause for a second to fully define afterload for everyone.
Good idea. If preload was the stretch before the pump, afterload is the resistance the heart has to pump against. Imagine trying to push open a very heavy door. High blood pressure means the systemic vascular resistance is high. That's high afterload.
So DHPs make the door easier to open.
Exactly. They relax the arterial system, lowering that resistance.
Yeah.
Less effort against resistance means less cardiac work and reduced oxygen demand. And the mnemonic is easy. Drugs ending in felopine cause a dip in blood pressure.
Then we have the second family, the phenylalanines.
This family is the heart specialist, and it's represented by one drug, verapamil. It acts predominantly on the cardiac muscle and the conduction system, the SA and AV nodes. Its primary effect is decreasing heart rate and contractility, making it functionally very similar to a beta blocker.
And finally, the third family, the benzothiazepines.
The hybrid, which is best exemplified by diltiazem. It acts on both the vessels and the heart, but it's a more balanced agent, though less potent in its specialized actions than the other two. It offers a good middle ground.
This difference in specialization means these 3 families are absolutely not interchangeable. So let's go to our next slide and look at choosing your CCB, a clinical comparison.
This comparison is where the risk and reward of CCBs really becomes clear. If we compare the vessel specialist, amlodipine, the heart specialist, verapamil, and the hybrid diltiazem, we see these clear trade-offs.
For afterload reduction, the DHPs, like amlodipine, they dominate. They're the most potent vasodilators.
They are. But look at the effect on heart rate. Because amlodipine causes such a rapid, significant drop in blood pressure, the body often compensates with a fierce reflex tachycardia. The heart speeds up to maintain blood flow to the brain.
Which can sometimes make the angina worse by increasing demand.
Exactly. And that's why verapamil and diltiazem are so different. They actively suppress the heart. Verapamil has the strongest negative chronotropic and inotropic effects.
And what about side effects?
DHPs like amlodipine famously cause ankle edema due to localized dilation of small vessels and that reflex tachycardia. Verapamil, because it's so potent in slowing the electrical system, can cause AV block and may precipitate or worsen existing heart failure. And interestingly, verapamil is well known for causing severe constipation. Diltiazem is generally milder, but carries risks like headache and bradycardia.
This brings us to the second absolute rule of cardiac pharmacology, the combination dangers. We established the synergy of beta blockers and nitrates. But here is the dangerous do, #2.
The safe combination is combining dihydropyridines, like amlodipine, with beta blockers. It's perfect. The DHP lowers the afterload, but the beta blocker completely prevents the dangerous reflex tachycardia that the DHP would otherwise cause.
A perfect pharmacological counterpoint.
It is. However, the dangerous combination is combining beta blockers with the other 2 families, verapamil or diltiazem. This is the don't do it combo.
Why is that so dangerous?
The danger is additive depressant effects. Both beta blockers and verapamil-diltiazem strongly slow the heart by acting on the SA and AV nodes, and they both reduce the force of contraction. Combining them can lead to profound, severe bradycardia, total heart block, catastrophic heart failure, or even cardiac arrest.
This is why checking the patient's medication history is absolutely critical before starting a beta blocker.
Absolutely.
Okay, this marks the end of our chronic management phase. We've managed the demand side of the scale. We now have to transition to the most urgent part of the story when that supply line fails catastrophically.
The acute crisis.
So now, coming to the next slide, we are shifting gears dramatically as we move to the crisis. A heart under attack. The story escalates from that partial chronic blockage to a complete, terrifying occlusion.
This is the definition of a myocardial infarction, MI, a heart attack. It happens when an unstable atherosclerotic plaque ruptures. This triggers the body's clotting mechanism. A blood clot, or thrombus, forms rapidly and completely seals the coronary artery.
And the heart muscle downstream.
It's starved of oxygen and nutrients. It begins to suffer ischemic necrosis. It starts to die.
The core principle here must be stated again and again. Time is muscle.
Every single minute that blockage persists results in irreversible damage to the myocardium. The goal of emergency treatment is twofold. First, rapid stabilization, and second, immediate reperfusion.
Opening the artery.
Opening the artery. The shift is from chronic management to emergency intervention.
Okay, let's go to the next slide and walk through the MI protocol. Immediate life-saving actions. These are the first 4 crucial steps taken the moment a suspected MI patient hits the emergency room.
The first, and arguably most important, is immediate anti-clotting action. This is antiplatelet therapy. Aspirin. A dose of 162 milligrams or 325 milligrams must be chewed and swallowed at once.
Chewed specifically for faster absorption.
Yes. Chewing allows the drug to be absorbed rapidly through the oral mucosa, getting the anti-clotting effect, working quickly to inhibit platelet aggregation and stop the clot from growing. If the patient has an aspirin allergy, we use clopidogrel, usually a large 300 milligram loading dose.
So we immediately inhibit the clot. Next, we address the debilitating pain and anxiety.
That's analgesia. Morphine. Intravenous morphine, typically 10 milligrams, is used for the relief of severe pain. But the rationale goes beyond just pain relief. Morphine is also a vasodilator, which decreases preload and reduces the cardiac workload.
And it calms the patient down.
It reduces their severe anxiety, which cuts the sympathetic drive, further lowering heart rate and blood pressure, all contributing to reduced oxygen demand.
And as a practical side note, we often pair the morphine with something else, don't we?
We do. Antiemetics like promethazine are commonly given concurrently because opioids frequently induce nausea and vomiting. Managing this is essential for patient comfort.
Step 3 is a familiar nitrate, but in a new high-intensity format.
5-E nitroglycerin. It's used here for persistent chest pain and, crucially, to treat acute left ventricular failure. But the critical caveat still applies. Avoid it if the patient is hypotensive or if we suspect recent PDE5 inhibitor use.
And finally, oxygen.
Low-flow oxygen 2,4-Lmin is administered if the patient's oxygen saturation is decreased, typically below 90–94%. And while the classic mnemonic is MNA morphine, oxygen, nitroglycerin, aspirin modern guidelines stress that aspirin should be first.
Right, PMNA helps you remember the components, but not the order.
Exactly. The full ongoing protocol is often summarized using the more comprehensive mnemonic thrombins too, but those initial 4 actions are the rapid, critical stabilization steps.
So once the patient is stable, we move to the absolute primary mission, opening the pipe. Let's look at the next slide, the MI protocol. Restoring blood flow is everything.
Reperfusion therapy is the gold standard for saving heart muscle. We have to restore coronary patency. The choice between the 2 methods is dictated by resource availability and time.
Method 1 is the ideal choice.
If the infrastructure is available, it's primary percutaneous coronary intervention, PCI. This is the mechanical approach. A cardiac catheter is guided to the clot, a small balloon is inflated to crush the blockage, and a stent is usually placed to keep the artery permanently open.
It's the gold standard because it provides an immediate, definitive opening of the vessel.
It does. But if you're in a rural hospital or time delays make PCI unfeasible, you have to rely on the chemical solution. Thrombolytic therapy, the clot busters.
How do these work?
Thrombolytic agents are powerful drugs designed to chemically dissolve the actual thrombus. Their mechanism is centered on converting the inactive protein plasminogen into the active enzyme plasmin. Plasmin is the body's natural clot buster. It degrades the fibrin meshwork that holds the clot together.
What are the key agents we need to remember in this category? Don't skip any.
The key agents are streptokinase, which is an older one, and the more modern tissue plasminogen activators, or TPAs, like alteplase, tenecteplase, and repteplase. These are highly effective, but they carry a significant risk of severe bleeding, including intracranial hemorrhage.
So they're only used when PCI is not readily accessible.
Exactly. And once the artery is open, either way, the immediate next step is preventing new clots. That's the role of anticoagulants.
So they don't dissolve clots, they prevent them.
Correct. They're given right after reperfusion to prevent reinfarction. The standard agents include low molecular weight heparin, LMWH, like enoxaparin or unfractionated heparin, given intravenously.
This concludes the acute intervention. We've stabilized the patient, inhibited the clot, and restored blood flow. Now we turn our attention to the long game.
That's right.
Now coming to our next slide, we need to talk about securing the future. Long-term pharmacotherapy post-MI. We've won the battle by saving the heart muscle, but the war against heart disease is fought in the years that follow.
This discharge regimen is perhaps the most important set of prescriptions a patient will ever receive. We categorize them as the 4 pillars of post-MI therapy. If you miss one pillar, you compromise the whole structure.
Pillar number 1, beta blockers like metoprolol or atenolol.
They are continued long-term, usually started within the first 24 hours. Their long-term role is vital. They reduce mortality significantly, decrease the size of any future reinfarction, and perhaps most critically, reduce the incidence of life-threatening ventricular arrhythmias.
A continuous brake on the heart. Pillar number 2, ACE inhibitors or ARBs like ramipril or valsartan.
Their core mission here is to prevent something called adverse cardiac remodeling. After a heart attack, the damaged tissue heals, but the healthy muscle often compensates by stretching and changing shape. The ventricle can become larger and less efficient, eventually leading to heart failure.
And how do ACE inhibitors stop that?
They block the production of angiotensin II, and ARBs block its receptor. By reducing angiotensin II, they lower systemic resistance and, crucially, reduce the effects of fibrosis and hypertrophy in the healthy part of the muscle. They prevent the chamber from ballooning out.
Pillar number 3, statins, like atorvastatin.
While lowering cholesterol is the headline benefit, the role of statins here is much broader. They are started aggressively, at high intensity, not just for lipids, but specifically to reduce subsequent thrombotic events. The deep dive insight is their pleiotropic effects.
The benefits independent of lipid lowering.
Yes. Statins are powerful anti-inflammatories, and they fundamentally stabilize the atherosclerotic plaques. They make the existing volatile plaques less likely to rupture, which is the event that triggers the whole MI cascade in the first place.
And pillar number 4, antiplatelet agents such as aspirin and clopidogrel.
These are continued daily. Aspirin is standard indefinitely. If the patient received a stent during PCI, they are typically placed on dual antiplatelet therapy, DAPT aspirin, plus a P2Y12 inhibitor like clopidogrel for usually 6 to 12 months.
And DTT is to prevent a clot from forming on the new stent.
Exactly. It prevents a catastrophic acute stent thrombosis. This incredible combination, these 4 pillars, is the blueprint for maximizing the patient's future health.
Okay, let's synthesize everything now. Coming to the next slide, the Strategist's Handbook, a summary of cardiac drugs. This is our chance to cross-reference the major classes.
The key is recognizing how the role of a drug changes based on the clinical scenario. Nitrates, for example, shift from being a sublingual rescue for angina to an IV agent used acutely in MI.
And the anti-clotting agents are a crucial distinction.
Yes. Antiplatelets, like aspirin, inhibit platelet aggregation and are essential in the immediate MI setting. Anticoagulants, like heparin, inhibit the coagulation cascade and are used after reperfusion. They serve 2 completely different stages.
And, of course, the thrombolytics, like alteplase, have 0 role in stable angina.
None. They are a high-risk, high-reward intervention used exclusively for reperfusion in an acute MI when the cath lab is inaccessible.
Yeah.
We also see the long-term players solidified. ACE inhibitors and statins are for secondary prevention post-MI.
Now we come to my favorite part. On the next slide, we have your memory palace. Tricks to master cardiac pharmacology. This is where we lock in the knowledge.
If you know the suffixes, you know the class and the primary action. This is the biggest hack in pharmacology. Cortisol. Beta blockers. They make the heart rate go LOL lower. Metoprolol, atenolol, cetapine, dihydropyridine, CCBs. They cause a dip in blood pressure. Amlodipine, bifidipine, cetapin. ACE inhibitors. They put the lid on the pressure. Or they're the April Fools who block angiotensin II's action. Ramipril, sartan. angiotensin receptor blockers, or ARBs. They are the sartans who block the angiotensin receptor directly. Valsartan.
We have to revisit those two critical dangerous duos one more time.
We must. Number one, nitrates plus PDE5 inhibitors like sildenafil. The risk is profound, uncontrolled hypotension, and immediate threat to life.
And number two?
Beta blockers plus non-DHP CCBs, so verapamil or diltiazem. This is the don't do it combo because of additive depressant effects on the heart's electrical system.
And for acute MI management, the famous classic mnemonic is MNA, morphine, oxygen, nitroglycerin, aspirin.
MNA is a great memory aid, but we have to reemphasize that the clinical priority is different. Antiplatelets, aspirin, should be given almost immediately, often before the others, because stopping the ongoing thrombotic process is paramount.
Finally, let's run through our last slide, the clinical gauntlet. Test your knowledge. Q&A. This is how we integrate everything.
Okay, question one. A 58-year-old man with stable angina is well managed on a beta blocker, but he presents to the ER with chest pain at rest that is not relieved by sublingual nitroglycerin. Why might the beta blocker be contributing to this new type of pain?
Okay, so the listener has to diagnose the new condition first. Pain at rest, unresponsive to nitrates, strongly suggests Prince-Metal variant angina, a vasospasm issue.
And the pharmacological answer lies in receptor theory. The beta blocker, by targeting beta-2 receptors, inadvertently blocks the body's natural vasodilatory mechanism. This leaves the vasoconstricting alpha-delta-1 receptors unopposed, which can dramatically worsen the coronary vasospasm.
A perfect example of knowing not just what the drug does, but what it leaves behind. Question 2. A patient arrives with a confirmed MI, but the rural hospital doesn't have a cardiac catheterization lab. After giving aspirin and morphine, what is the next most critical class of drug to administer?
This is about triage. If primary PCI is unavailable, you must immediately choose the chemical solution. Thrombolytic therapy. Drugs like alteplase or connectoplase are critical to dissolve the thrombus and achieve rapid reperfusion.
And finally, question 3 tests the long-term plan. A patient is being discharged after an MI where he received a stent. His medications include aspirin, clopidogrel, metoprolol, ramipril, and atorvastatin. Explain the primary role of each key medication.
This tests the 4 pillars. Aspirin clopidogrel is DAPT to prevent stent thrombosis. Metoprolol, the beta blocker, reduces mortality and arrhythmias. Ramipril, the ACE inhibitor, prevents adverse cardiac remodeling. And atorvastatin, the statin, is crucial for aggressive plaque stabilization. That cocktail is survival management.
What an incredible journey through the heart's delicate chemical balance, from the microscopic CGMP pathway all the way to the macro strategy of the 4 pillars.
It really covers the spectrum, from understanding that simple oxygen imbalance in angina, through the classes of chronic drugs that manage demand, and finally to the high-speed, life-saving protocol for a full MI.
We've seen that cardiac management is a dynamic balance, not just reducing demand, but strategically using drugs that counteract each other's side effects, creating powerful synergy.
And knowing the dangerous duos, the verapamil beta blocker combo and the PDE5 nitrate combo, is perhaps as important as knowing the benefits of the drugs themselves.
This knowledge is vital for application, whether you're a professional or just trying to understand your own health.
It is. But I want to leave you with one final thought. We spent this entire deep dive decoding the pharmacology that treats the effects of heart disease, the blockages, the spasm, the high demand.
Right, the chemical solutions to a mechanical or structural failure.
But consider the power of the most potent drugs of all, the lifestyle changes. Diet, consistent exercise, stress management. These factors directly target the root cause of the entire story, the atherosclerotic plaque buildup.
The thing that started this whole mess.
Exactly. If the MI is caused by the plaque rupturing, and the plaque is caused by these lifestyle factors, what role do we all play in preventing the oxygen battle before it even begins, potentially making the need for this complex drug cabinet less urgent? That's the challenge for all of us. We were diving into the human heart, the single hardest working muscle in your body.
Yeah.
And what happens when this, this perpetual relentless pump starts to run out of steam?
It's an astounding piece of machinery. I mean, just think about it for a second. It beats over 100,000 times a day.
100,000.
Pushing thousands of liters of blood, and it never, ever stops. But when it fails, the consequences just cascade throughout the entire body.
And that's our mission today. We're going to take 16 really dense source slides that detail that failure, congestive cardiac failure, or CCF, and the the very complex multi-drug strategy used to manage it.
And our goal is to turn all of that complexity into something utterly clear, fascinating, and hopefully memorable for you.
That's the challenge. We're going to simplify some advanced physiology and pharmacology. And we're starting with our core analogy, which is just. It's absolutely key to understanding everything that follows. Forget the poetry for a moment. We are looking at the heart purely as a mechanical pump.
Exactly. If you can visualize it as this sophisticated high-pressure machine, the failure points become instantly clear. If we look at the first slide, we can actually map the heart's labels directly onto the components of a pump.
Okay, let's do that.
Yeah.
So let's identify the parts. When we're talking about the left ventricle, which has to push blood out to the entire body, what does that translate to mechanically?
That's the muscle. It's the powerhouse.
Yeah.
It is the pressure chamber and really the piston mechanism.
Okay.
That chamber has to generate immense force to overcome the pressure in your arteries. Its health really dictates the power output of the whole system.
And what about the input side? The blood coming back from the body, collecting in the right atrium?
That's your intake valve. It's just handling the flow that's returning to the pump.
Simple enough.
And the actual muscle tissue that's driving the whole thing, the myocardium, that's your engine block. That's the piston mechanism itself.
Right.
And finally, you have the aortic valve and the pulmonary valves. They snap shut to make sure blood moves in only one direction.
So they're the discharge valves.
They're your discharge valves. If any of these mechanical components, the piston, the intake, or the discharge resistance, if any of them fail, the entire system breaks down.
That mechanical framing is perfect. Because
Yeah.
now that we understand the machine, we can start to understand the struggle.
Now, as we come to the next slide, it starts to define the problem. The condition is congestive cardiac failure, or CCF.
Right.
When people hear heart failure, they panic. They think the heart is stopping. But that's not what CCF is.
No, that's the key distinction. In CCF, the heart is either too weak to squeeze effectively or it's too stiff to fill up properly. It's struggling to meet the metabolic demands of the body.
And the primary measure of that struggle is something called cardiac output, or CO.
Can you define cardiac output for us again, but tell us why it matters so much clinically?
Sure. Cardiac output is simply the total volume of blood the heart pushes out per minute. If we stick to our water pump analogy, it's the flow rate.
Flow rate, got it.
In heart failure, CO is, by definition, reduced. If the pump is weak, that steady stream becomes a pathetic trickle. And why does it matter? Because that trickle means less oxygen and fewer nutrients are reaching your tissues, and that kicks off a crisis.
And that reduced flow rate immediately manifests as two very distinct problems for the patient. The twin miseries of what the sources call forward and backward failure. Let's start with forward failure.
Forward failure is the direct result of that low CO. Not enough blood is being pushed forward to the organs and the tissues.
Okay.
So when your tissues, especially your brain and your skeletal muscles, don't get enough oxygen, they enter a state called tissue hypoxia.
And if my body's critical systems are being starved of oxygen and energy, what does that actually feel like for the patient?
It feels like profound exhaustion. They experience this debilitating fatigue and weakness. Imagine an entire city trying to run on generators because the main power plant, the heart, is delivering low voltage.
Right. Everything just slows down.
Every system slows down. The brain might be a little foggy, and any kind of physical exertion becomes almost impossible.
Okay, so that covers the supply side, the lack of flow forward.
Yeah.
Now let's talk about backward failure. This is where the term congestive comes from, right?
Exactly. This is the plumbing disaster. If the pump can't push the fluid out fast enough, the fluid coming in has nowhere to go. It backs up.
The traffic jam.
It creates a massive hydrostatic pressure problem. It's exactly like a traffic jam right before a toll booth.
And where does that backup manifest most dangerously?
It manifests as congestion. When the left side of the heart fails, the blood backs up into the lungs. That leads to dyspnea, shortness of breath.
So they feel like they're drowning.
Patients often describe it as feeling like they're drowning in their own fluid. And when the right side fails, blood backs up into the body's systemic circulation, causing swelling, most visibly in the lower extremities, that's peripheral edema, or those classic swollen ankles.
So the CCF patient is completely trapped in this cycle. They are tired and weak because the factory is starved. That's forward failure. And they are breathless and swollen because the pipes are backed up. That's backward failure. It's a dual crisis.
Which requires a dual solution. And that brings us directly to the next slide, which outlines the mechanical trinity of problems we have to address.
Right.
Everything we treat pharmacologically, every drug connects back to one of these three core defects. We need to identify these three mechanical breakdowns.
Okay, the first one is the overflowing reservoir, or increased preload. Let's define preload in the context of the muscle fibers.
Preload is technically defined as the degree of ventricular stretch at the end of diastole. That's the resting or filling phase.
Yeah.
It's the amount of blood filling the heart chamber right before it squeezes. Think of it like stretching a rubber band. A little stretch helps it snap back harder. That's the Frank Starling mechanism.
But too much stretch.
But too much stretch, and the band is weakened and just becomes ineffective.
And in CCF, we have way too much stretch because the pump is weak and it just can't clear the fluid fast enough.
Precisely. The chamber overfills, causing that backward failure. This increased volume results in massive pressure in the pulmonary vessels, leading to increased pulmonary capillary pressure.
I remember the clinical signs we discussed.
And the signs are dramatic. Dyspnea, which is shortness of breath, and a really classic sign, orthopnea.
Orthopnea.
Think about why someone with CCF sleeps on 3 pillows. When they lie flat, gravity sends even more venous blood back toward their chest, and it instantly overwhelms the failing pump. Breathing becomes nearly impossible.
Lying down actually shifts the fluid and makes the overflow worse.
Exactly.
So that's volume management. Problem number 2 is the difficulty of ejection, the kinked hose, or increased afterload.
Afterload is the resistance the heart has to push against to get the blood out. If the left ventricle is our piston, afterload is the pressure in the aorta that the piston has to overcome just to open the discharge valve.
It's the back pressure.
It is. And in a sick circulatory system, the arteries are pathologically tight. This is called increased peripheral vascular resistance, or PVR. Imagine trying to pump molasses through a straw.
Right.
The heart is already a weak engine, and now you're forcing it to push against this incredible resistance.
And that significantly drives our forward failure, preventing that essential oxygen from getting to the tissues. The heart is pumping, but the resistance is so high that the actual volume pushed out is tiny.
Correct. It wastes precious energy struggling against that high resistance. And finally, the third and most fundamental issue is the weakening motor, or reduced contractility.
This is the actual engine failure.
It is. Contractility is the intrinsic power of the muscle fibers themselves.
Wow.
In CCF, the myocardium, that muscle wall, is tired, often damaged by years of stress or scarred from a previous heart attack.
It just can't squeeze as hard.
It simply loses its inherent ability to contract forcefully. It's like having a car engine that can only run at 50% power no matter how much gas you give it.
So we have this vicious mechanical trifecta, too much fluid backing up, that's preload, a terrible struggle against resistance, that's afterload, and the power generating the squeeze is weak, which is contractility.
And that leads us to the crucial realization, which is on our next slide. The body senses this drop in cardiac output and it panics. It activates these primitive survival systems that are, tragically, the absolute worst thing for the heart in the long run.
This is the great paradox of heart failure. The body tries to save itself, but those rescue efforts actually accelerate the decline. Let's look at the body's rescue plan that backfires.
When the cardiac output drops, the body interprets it as an acute crisis, like a major bleed.
I see.
So it activates these emergency measures designed to survive a crisis, not a chronic illness. These systems try to increase blood pressure and blood volume, which is exactly what a failing heart cannot handle.
And the first emergency system is the stress response. Increased sympathetic activity, the adrenaline rush.
This floods the system with catecholamines, adrenaline, noradrenaline. It revs up the heart rate, causing tachycardia, and it aggressively squeezes the blood vessels, vasoconstriction.
And temporarily that might work.
Temporarily, this raises blood pressure and CO. The patient might feel a momentary boost, but the weak motor is now being overdriven.
And that's where the long-term damage comes in.
Precisely. If you force a weak muscle to work harder and faster chronically, it rapidly exhausts itself. And what's more, constant high levels of adrenaline are actually toxic to the heart muscle cells themselves.
Toxic.
Yes. They lead to cell death and inflammation. This chronic hormonal barrage accelerates the remodeling process we'll talk about and increases the risk of dangerous sudden arrhythmias. We are essentially burning the engine out faster.
And the second highly complex system is increased renin-angiotensin-aldosterone system activity, RAAS. This is the system that our pharmacological heroes spend most of their time blocking.
RAAS is the ultimate volume and pressure regulator. When the kidneys perceive low blood flow, they release renin, which kicks off a cascade leading to the creation of angiotensin II. And angiotensin II is a truly potent hormone.
Walk us through its two main effects in heart failure.
First, angiotensin II is a monster vasoconstrictor. It tightens blood vessels globally. In the context of heart failure, this severely kinks the hose.
Worsening afterload.
Right. It makes it nearly impossible for the weak heart to push blood out. Second, it triggers the release of aldosterone from the adrenal glands.
And aldosterone is the salt and water retention hormone.
Yes, aldosterone tells the kidneys, keep all the salt, keep all the water. This drastically boosts blood volume, which adds more and more fluid to our overflowing reservoir, dramatically worsening preload and the patient's congestion symptoms.
So the two primary effects of RAA's vasoconstriction and fluid retention simultaneously worsen the two mechanical defects of preload and afterload. It's a truly vicious, self-perpetuating cycle.
And that cycle feeds right into the third long-term damage mechanism, myocardial hypertrophy and remodeling.
The heart tries to compensate by getting bigger, but it's a pathological change.
That's exactly. It's hypertrophy, but it's disorganized and fibrotic, meaning it's scarred and stiff. The heart changes its fundamental shape and thickness, becoming less elastic and far less efficient.
So these rescue plans are actually driving the disease forward.
Yes, chronic activation of both the sympathetic system and RAAS directly drives this unhealthy remodeling, locking the heart into a cycle of progressive failure.
So the goal of modern CCF management is not just to relieve symptoms today, but to aggressively interrupt this catastrophic hormonal feedback loop that is destroying the heart muscle long term.
Precisely. And that brings us to the next slide, the therapeutic arsenal. Our mission is explicitly a three-pronged attack to help the heart.
Strategy 1.
What?
Reduce preload. We have to drain the overflowing reservoir by reducing volume and relaxing the veins.
Strategy 2. Reduce afterload. We have to unkink the hose by forcing the arteries to relax, lowering that peripheral resistance.
And strategy 3. Enhance contractility. Carefully boosting the weakening motor, knowing that this is often a symptomatic fix, but sometimes critically necessary.
Let's start with the immediate symptomatic relief, tackling that overwhelming volume. And as we come to the next slide, we meet the first responders on the scene, the diuretics.
Diuretics are the pump-out crew, dedicated to reducing preload. How do they achieve this superpower of making us excrete salt and water?
They target the kidneys, which are responsible for balancing fluid and electrolytes. Diuretics interfere with the transport of sodium, Na plus C, in different parts of the nephron, which is the kidney's functional unit.
And where sodium goes, water follows.
That's the rule. By forcing the excretion of Na plus, they decrease total blood volume and lessen the fluid return to the heart.
The result must be immediate relief for the patient.
Huge relief. Less congestion, lower preload, and symptom reversal. The dyspnea lessens and the peripheral edema shrinks. The diuretic team is varied, reflecting different levels of potency and side effects.
Okay, break down the team for us, starting with the heaviest hitters.
The loop diuretics are the powerhouse crew. This includes furosemide, bumetanide, and torsemide. They're named because they work on the loop of Henle, a segment of the kidney tubule.
And they are potent.
They are the most potent diuretics available for heart failure. They can excrete up to 25% of the filtered sodium, making them essential for managing acute volume overload. They are generally the first-line choice when congestion symptoms are severe.
Okay, and the second group, the thiazides.
The thiazide diuretics, like hydrochlorothiazide and metolazone, are milder. We call them the helpers. They act a little later in the kidney tubule.
So when would you use them?
They're often used synergistically with loop diuretics in patients who are particularly fluid-retaining or who have developed some diuretic resistance. Using two different sites of action often allows us to squeeze out even more excess fluid.
And finally, the smart defenders, the aldosterone antagonists. We briefly touched on them when we were discussing RAS.
Spironolactone and eplerenone. Their role is so much more critical than just diuresis, which is why we call them smart. Yes, they cause mild fluid loss because they block aldosterone's salt-retaining effects.
But their main benefit is something else.
But their survival benefit comes from blocking aldosterone's direct detrimental effects on the heart muscle, stopping fibrosis and remodeling.
So while the loop diuretics make the patient feel better today, the aldosterone antagonists are helping the heart survive tomorrow.
Exactly. And they have another major perk. They are potassium sparing. Furosemide causes massive potassium loss. Aldosterone antagonists help prevent that K+ loss, which becomes a vital consideration when we look at digoxin later.
That brings up a critical field note from the sources: potassium monitoring.
It is paramount. Since therapy often starts with a loop diuretic like furosemide, we are intentionally driving out potassium. This potassium loss, or hypokalemia, is a major side effect.
So you have to watch it closely.
We must monitor serum K+ levels religiously because low potassium dramatically increases the risk of toxicity from other heart failure drugs.
We've drained the reservoir. Now we have to turn off the water main that is trying to refill it and unkink the hose. This is where, on the next slide, the RAAS inhibitors come in. These are the master strategists.
These drugs truly change the course of heart failure management. Their mission is to disarm the body's self-destructive threat system, impacting both preload and afterload simultaneously.
Let's start with the ACE inhibitors, the cornerstone of treatment.
The ACE inhibitors, or ACI, these are drugs like enalapril, lisinopril, and ramipril. They all share the suffix, the bearpril.
Right, the prils.
Our mnemonic chillpril reminds us they chill out the heart. They work by blocking angiotensin-converting enzyme, or ACE, the enzyme responsible for turning the relatively inactive angiotensin I into the hyperpotent angiotensin II.
So we prevent the powerful hormone from even being created. What are the comprehensive results?
Phenomenal results across the board. First, without angiotensin II, massive afterload reduction occurs. The arteries relax, the hose unkinks. Second, the venous system relaxes, contributing to preload reduction. Third, we prevent the aldosterone surge, further aiding fluid balance, and most critically, they are proven to slow down and even reverse that harmful ventricular remodeling.
These are the definition of life-saving drugs.
They absolutely are. They are standard therapy for all grades of CCF because they improve symptoms, decrease hospitalizations, and dramatically decrease mortality. The fact that they improve survival means they target the underlying pathology, not just the symptoms.
But the sources warn about a common side effect that forces a lot of patients off the prils.
That's the persistent, irritating dry cough. It happens because ACE also breaks down bradykinin, a chemical mediator.
Okay.
When you block ACE, bradykinin levels rise, and that irritates the respiratory tract. For maybe 10 to 20% of patients, the cough is just intolerable.
And if they can't tolerate the cough, that's when we deploy the second team, the angiotensin receptor blockers, or ARBs.
That's the team of losartan, candesartan, and valsartan. They all end in sartan. Our mnemonic is the Spartan blocks the receptor.
I like that one.
They allow angiotensin II to be produced, but they block its action at the receptor level. Think of them as jamming the receiving signal. And because they don't interfere with bradykinin breakdown, they don't cause the cough.
Do they offer comparable benefits to the ACE inhibitors?
For CCF, yes, they are considered therapeutically equivalent in terms of reducing mortality and slowing remodeling. They serve as a crucial alternative for patients intolerant of ACEI.
And we also have a newer team member that attacks the RAAS cascade at the very start.
The direct renin inhibitor, aliskiren. Renin is the enzyme released by the kidney that starts the whole cascade. Aliskiren stops the pathway right there. While promising, ACEI and ARBs remain the primary foundation for most patients.
That's an impressive systemic strategy, but sometimes we need even finer, more specialized control over the vascular system. So the next slide brings us to the specialists. Other vasodilators?
These agents are used for their precise targeting of the pipes. We use them when the RAAS inhibitors aren't providing enough afterload or preload reduction or in an acute crisis.
Let's categorize them by their target. Start with the vasodilators, focused on preload.
Nitroglycerin and isosorbide dinitrate are the primary examples. They primarily relax the veins. Veins are highly compliant. When they relax, they become larger holding tanks.
Ah, so the blood pool's there.
This allows blood to pool in the periphery, which significantly reduces the volume of blood rushing back to the heart. It's a very effective way to quickly drain the overflowing reservoir and reduce pulmonary congestion.
So they lower the fluid returning to the heart, but they don't necessarily help the heart pump against resistance. That's the job of the arterial dilators.
Correct. Hydralazine and minoxidil. They primarily relax the arteries. This is pure afterload reduction, a dramatic unkinking of the hose. They significantly reduce the systemic resistance the weak left ventricle must overcome.
If you drop the resistance too fast, does the body have a reaction?
It does. A common issue with pure arterial dilators is reflex tachycardia. The sympathetic nervous system senses the rapid drop in blood pressure and panics, releasing adrenaline to speed up the heart.
Which is counterproductive.
Very counterproductive in heart failure. as the last thing we want is to speed up an already weak heart.
And for those acute, severe emergencies, we need a drug that does both and does it fast.
That's the mixed arteriolar and vasodilator sodium nitroprusside. This is a fast-acting, incredibly potent agent used strictly intravenously in the ICU setting for severe heart failure emergencies. For instance, when a patient presents with flash pulmonary edema and dangerously high blood pressure.
It's the quickest way to hit both preload and afterload simultaneously.
It is.
Yeah, we spent so much time talking about blocking the RAS system, but what about the other harmful emergency mechanism, that constant sympathetic bombardment? The next slide brings us to the unlikely allies, beta blockers. And this is the ultimate paradox of heart failure treatment.
It truly is. 20 years ago, giving a patient with a failing heart a drug that slows the rate and temporarily reduces contractility would have seemed, well, reckless.
Yeah.
The paradox is this. While beta blockers look harmful in the short term, they are monumental lifesavers in the long term.
Explain the superpower again. Why are we giving a heart that needs strength a drug that can dampen its drive?
We are shielding the heart from chronic toxicity. The heart is under constant assault from adrenaline and other stress hormones. These catecholamines are constantly stimulating the heart muscle receptors, causing damage, cell death, and promoting that harmful remodeling we discussed.
So the beta blockers are a shield.
Beta blockers literally shield the cardiac cells. They block the CATA1 receptors from this toxic barrage.
So the patient takes a temporary hit to their sympathetic drive, but the long-term payoff is structural stability and repair.
Exactly. The long-term result is that the heart's own structure and function improve. We see slowed down ventricular remodeling, a reduction in the size of the enlarged left ventricle, and an increase in the crucial ejection fraction, the amount of blood the heart pumps out with each beat.
And they help with rhythm too, right?
They also stabilize the electrical system, decreasing dangerous arrhythmias.
Which ones are safe to use? I know you can't just reach for any beta blocker.
No, absolutely not. Only specific agents have shown mortality benefits in chronic heart failure. The team is metoprolol, specifically the long-acting succinate version, bisoprolol, carvedilol, and nebivolol.
And carvedilol is a popular choice.
Carvedilol is often favored because it's a non-selective beta blocker that also offers an additional alpha-1 blockade, which helps reduce afterload, and it provides beneficial antioxidant effects.
And the critical field note about initiation. This is not a drug you start at full dose.
Never. If you block the sympathetic drive abruptly, the heart, which is relying on that adrenaline just to function, can crash.
So you have to go slow.
Therefore, therapy must be started at an infinitesimally low dose, often 1/16 of the target dose, and increased very slowly over weeks or months, only when the patient tolerates it. This slow titration is essential because their long-term use improves symptoms, reduces hospitalization, and, along with RAAS inhibitors, drastically decreases mortality. These are non-negotiable for long-term survival.
We've mastered the three-pronged attack to reduce the burden on the heart. We've drained the reservoir, unkinked the hose, and protected the motor from hormonal burnout. Now, let's look at directly boosting the motor's power. And coming to our next slide, this brings us to a historical figure, digoxin, a cardiac glycoside. Digoxin is the classic hero. Its mission: directly boost the motor's strength, achieving a positive inotropic effect. It has an incredible history, derived from the foxglove plant Digitalis purpurea. William Withering first described its use for dropsy, or what we now recognize as severe edema from heart failure, way back in the 1780s.
Wow. And the mechanism here is a beautiful indirect molecular dance involving sodium and calcium. We need to detail the 5-step process so you listening can understand exactly how it increases contraction force.
We must. It's intricate, so let's slow down and trace the path inside the heart muscle cell. Step 1. Digoxin walks right up to the heart muscle cell membrane and specifically blocks and inhibits the crucial Ni plus K plus ATPase pump.
So it stops that pump. Yes, and this pump is normally working hard, keeping sodium low inside the cell and potassium high. Step 2. With the pump stopped, sodium can no longer be actively kicked out. Therefore, sodium builds up inside the cell.
So you have a high sodium concentration inside the cell now.
Right. Step 3. The cell has another system for balancing sodium and calcium, the NAM plus K plus exchanger. This exchanger normally uses the low internal sodium gradient to pump calcium out of the cell.
But now the sodium's high inside.
But because internal sodium is now high, from step 2, the exchanger slows down dramatically. Step 4. If the pump pushing calcium out is slowed, calcium stays put. More calcium stays inside the heart muscle cell.
Okay, so now we have high sodium AND, high calcium inside.
Intracellular calcium concentration rises dramatically.
Hmm.
Step 5, this surplus calcium is available during the next heartbeat cycle. Calcium is the trigger for muscle contraction. Thus, the extra calcium leads to a much more forceful and complete contraction.
It's a remarkable chain reaction. It doesn't put the foot on the gas directly. It just prevents the cell from taking the calcium out, and the result is a much stronger squeeze.
Yes. The digitalized heart contracts more forcibly, increasing cardiac output, and we call this agent a cardiotonic, but this power comes with a monumental risk.
And that brings us to the next slide, digoxin. A hero with a dark side. Its therapeutic window is notoriously narrow. The therapeutic dose is dangerously close to the toxic dose.
That's the great challenge of digoxin management. We need constant vigilance. It works, but it's unforgiving.
Let's review its actions. We know about the positive inotropy, the increased force, but it has two important electrical effects too.
Yes, in addition to the desired increased force, the positive inotropy, it has powerful effects on the electrical system. It slows the heart rate, that's a negative chronotropic effect, by increasing vagal tone, and it decreases conduction through the AV node.
Which is useful for certain patients.
This makes it particularly useful for CCF patients who also have atrial fibrillation, as it both strengthens the beat and controls the dangerously fast rhythm.
What are the telltale signs of the toxicity outside the heart? The extracardiac effects.
The extracardiac effects often serve as the early warning system. These include GI symptoms like anorexia, nausea, and vomiting, because digoxin stimulates the chemoreceptor trigger zone in the brain.
And the famous visual side effect.
But the classic, most memorable sign of high doses is the CNS effect. Confusion, disorientation, and the infamous visual disturbance known as xanthopsia, seeing blurred or yellow halos around lights.
And the true danger is what happens to the heart's electrical system.
Exactly. The real danger is cardiac. Digoxin can cause virtually any type of arrhythmia. It irritates the heart muscle electrically. The most common and dangerous are ventricular premature beats and severe AV block, where the electrical signal can't pass properly from the atria to the ventricles.
If we were looking at an ECG, how would toxicity manifest?
You'd see classical changes. A prolonged PR interval, a distinctive scoop-shaped ST segment depression, and T-wave inversion. These are huge red flags.
Since the margin for error is so small, we need a high-stakes emergency protocol. So let's look at the next slide. Mission protocol. Managing digoxin toxicity. What factors immediately increase the risk of a patient tipping over the edge?
The single most critical piece of field intelligence is hypokalemia, or low potassium. This is a critical factor because digoxin competes with potassium for binding sites on that Na plus K plus AT pace pump.
So if potassium is low, digoxin has less competition.
If potassium is low, digoxin has far more available binding sites, increasing its concentration and effect dramatically. And since patients are often on loop diuretics, like furosemide, that actively deplete potassium, the risk is inherent to the treatment plan.
That interconnectedness makes K plus maintenance vital. What other factors contribute?
High calcium levels, hypercalcemia, also increase toxicity, as does low magnesium, hypomagnesemia. Since digoxin is predominantly cleared by the kidneys, renal failure rapidly leads to drug accumulation. And, of course, the elderly are always more susceptible due to slower metabolic rates.
If toxicity is confirmed, what's the strict step-by-step treatment protocol?
Step 1. Immediate discontinuation. Stop digoxin and any K+ by depleting diuretics instantly. Step 2. Intensive monitoring. The patient needs to be in an ICU for continuous ECG monitoring to catch arrhythmias as they start.
Next, we fix the electrolyte imbalance.
Step 3. Correct electrolytes. We administer potassium chloride, KCl, even if potassium is at the low end of normal, as KCl is often the first-line drug for many digoxin-induced tachyarrhythmias. It helps to displace the digoxin from the pump.
And if the dangerous ventricular arrhythmias begin.
Step 4. Treat arrhythmias. For ventricular arrhythmias, the drug of choice is lignocaine, also known as lidocaine. For supraventricular issues, we might use propranolol. If the patient develops dangerous bradycardia or a severe AV block, we use atropine or temporary cardiac pacing to speed the rhythm up.
And what about the ultimate rescue drug?
Step 5. The antidote. For life-threatening toxicity, severe block, or malignant ventricular arrhythmias, we use digoxin antibodies, or digibind. These are antibody fragments that bind to the digoxin in the blood, neutralizing it and pulling it out of circulation.
So they just mop it up.
They do. Though costly, they are profoundly effective in a true crisis.
That discussion highlights that digoxin is generally reserved for symptom control, not survival. For acute crises, especially when the motor is truly sputtering, we need immediate intravenous help. Let's look at the next slide, the elite squad. Inotropes for acute heart failure. These are the rescue agents.
These are not maintenance drugs. These agents are used for short-term support, typically in the hospital setting when cardiac output has dropped dangerously low, such as right after a major heart attack or cardiac surgery.
Start with dobutamine. It's a synthetic catecholamine, right?
Yes. Dobutamine is a highly selective AR1 agonist. This means its superpower is a powerful, direct, positive inotropic effect, a much stronger contraction, with minimal effect on heart rate or peripheral blood pressure.
So it's a pure pump booster.
It dramatically increases CO, giving the pump the boost it needs to get past a short-term crisis.
Next is dopamine, which is a complex agent because its effects are heavily dependent on the dose.
Dopamine is a natural catecholamine that acts on different receptors at different concentrations. We have to be very mindful of the dosage here. At a low dose, it acts on D1 receptors, primarily dilating the renal arteries.
So it helps the kidneys.
It increases blood flow to the kidneys, increasing urine output. This is crucial if the kidneys are failing due to reduced CO. At a moderate dose, it acts on AR1 receptors, providing that positive inotropic kick-increasing contractility in CO.
And the high dose.
At a high dose, it hits the AR1 receptors, causing intense generalized vasoconstriction. This massively worsens afterload and is generally avoided in CCF unless the patient is in severe shock.
So we need to carefully match the dopamine dose to the patient's specific pathology. Do we need renal flow or do we need cardiac boost?
Precisely. And finally, let's discuss the fascinating class known as the inodilators.
Drugs like inerenone and milrinone, the PDE3 inhibitors, how do they manage to boost the motor and unkink the hose simultaneously?
Their mechanism is elegant. They inhibit the enzyme phosphodiesterase 3, or PDE3, which is responsible for breaking down cyclic AMP, or AMP, inside cells. By keeping CAMP levels high, we get two simultaneous effects. High CAMP in the heart leads to positive inotropy, a stronger squeeze. And high CAMP in the smooth muscle of the blood vessels leads to vasodilation, lower afterload.
That dual action is exactly what a failing heart needs: power and less resistance.
They are powerful acute agents. Milrinone is generally preferred over inerenone because it's more potent and has a more favorable side effect profile. It avoids the severe thrombocytopenia or low platelet count that can occur with inerenone.
We've covered the classics, but medicine keeps moving forward. The biggest leaps in CCF survival have come from identifying and blocking new pathways. Let's talk about the next slide, the new wave of heroes.
The most significant recent advancement is the neprilysin inhibitor, sacubitril. You never see sacubitril alone. It is always paired with an ARB, specifically valsartan, in a combination known as an ARNI.
What exactly is neprilysin and why do we want to block it?
Neprilysin is a natural enzyme that breaks down beneficial hormones in the body, specifically the natriuretic peptides, AMP and BNP. These peptides are the body's natural counter-regulatory system to RAS.
They're the good guys.
They promote vasodilation, reduce blood volume, and block fibrosis. They are the good guy hormones.
So sacubitril stops the destruction of the good guy hormones, while valsartan blocks the powerful bad guy hormone, angiotensin II.
That's the elegant strategy. You inhibit the enzyme that degrades the good peptides, boosting their effects, while simultaneously blocking the harmful RAS system. This combination is used for severe heart failure, dramatically slows disease progression, and is now firmly on the VIP list, proven to decrease mortality.
What about those specific, tricky cases where the patient has overwhelming fluid but dangerously low sodium levels?
That's where the vasopressin receptor antagonists become essential. Tolvaptan and conivaptan. Their superpower is blocking the action of vasopressin or antidiuretic hormone ADH.
And what happens when you block ADH?
When you block ADH, the kidney excretes water only without losing electrolytes.
That's selective water loss, or aquaresis. Why is that crucial in hyponatremia?
In severe heart failure, the body often retains so much water that the sodium in the blood gets diluted. That's hyponatremia. If you give a regular diuretic, you lose both salt and water, potentially making the low sodium worse.
I see.
Vaptans specifically allow the excretion of free water to correct the volume overload and the low sodium simultaneously.
And finally, we can even administer the beneficial natriuretic peptide hormones directly.
That's nasiratide, which is a recombinant human form of brain natriuretic peptide, or BNP. It is a powerful, direct vasodilator. It's used intravenously to rapidly relieve that terrible dyspnea in cases of acute decompensated heart failure by acting directly to relax blood vessels and increase urine output.
It's abundantly clear that treating heart failure is not a matter of finding one magic bullet, but rather assembling a complex team of drugs to attack different pathways. And that brings us to the next slide, assembling the team. A comprehensive strategy.
The modern approach recognizes that heart failure management is a multi-pronged assault that combines lifestyle modification with layered pharmacological agents. We have a great mnemonic to organize the fundamental pillars of management, the D's of CCF management.
Let's review those functional pillars.
First, diet, the absolutely foundational step. Salt restriction is mandatory because salt dictates fluid retention.
Right?
Second, diuretics, to manage fluid overload and drain that overflowing reservoir. Third, dilators, specifically the vasodilators. This is the cornerstone therapy, the ACE inhibitors, or ARBs, disarming the RAAS threat system.
Okay.
Fourth, digoxin, for symptomatic relief and rate control, particularly important when a patient also has coexisting atrial fibrillation. And finally, dopamine dobutamine, reserved for acute decompensation and high-stakes rescue missions.
Now let's re-emphasize the most important insight we've gained, the difference between symptom relievers and lifesavers. Who are the mortality reducers, the VIPs?
These are the classes of drugs that fundamentally change the long-term prognosis by blocking the harmful hormonal and remodeling pathways. If a CCF patient is diagnosed with reduced ejection fraction heart failure, they should ideally be on 4 classes of these VIPs, unless contraindicated.
Let's list them one more time for everyone.
1. ACE inhibitors, or ARBs, the systemic threat disarmers. 2. Beta blockers, the protective shield. 3. Aldosterone antagonists, the smart defenders that block remodeling. And 4. Sacubitril valsartan, the new wave ARNI that boosts natural defenses.
Let's talk about the magnitude of their collective impact. If we start with the RAS inhibitors and beta blockers, how much does adding an aldosterone antagonist or an ARNI boost the patient's prognosis? Is the benefit marginal or monumental?
It is monumental. Each class provides an incremental and statistically significant reduction in hospitalization and mortality risk. For example, adding an aldosterone antagonist like spironolactone to an ACEI and beta blocker regimen can reduce the risk of death by another 30%.
30%.
And the ARNI, sacubitril valsartan, has shown superiority over ACE inhibitors alone in reducing death and hospitalizations. We don't just add them because they look good on paper, we add them because they compound the survival benefit. The goal is to aggressively layer these VIPs to halt the progression of the disease entirely.
That layering effect is the definition of modern CCF management. It's a holistic pharmacological team effort.
It is. The goal is to maximize the time the heart can spend recovering and minimize the time it spends under attack from its own faulty systems.
That was an exhaustive journey through the mechanics of failure and the team of heroes deployed to stabilize and heal the heart. So let's cement this knowledge with our final slide, knowledge check. Critical missions and field intel. We've organized 3 scenarios here to ensure you have the key takeaways locked down.
Ready for the quiz?
Question 1. A patient on furosemide, which is a loop diuretic, and digoxin reports seeing yellow halos around lights and is experiencing intense nausea. What is the most likely cause and the most critical electrolyte to check immediately?
The answer is absolutely digoxin toxicity. The yellow vision, or xanthopsia, combined with the GI upset is pathognomonic.
And the electrolyte?
The most critical electrolyte to check is potassium K+. Furosemide is highly effective but causes hypokalemia, and that low K+ dramatically enhances digoxin's binding to the NAC-A ATPase pump, making the toxicity far, far worse. Checking and correcting the potassium is often the first life-saving intervention.
Question 2. Besides providing symptomatic relief by draining excess volume, which diuretic class provides a distinct long-term mortality benefit in CCF, and why?
That would be the aldosterone antagonist spironolactone, or eplerenone. They offer the survival benefit because their primary action is blocking the harmful effects of aldosterone, which drives cardiac fibrosis and ventricular remodeling, regardless of their diuretic effect. They are one of the 4 VIPs.
Excellent. And the final nuanced question on toxicity management. Question 3. Why is lignocaine or lidocaine the drug of choice for ventricular arrhythmias caused by digoxin when other antiarrhythmics exist?
This is critical. Lidocaine is preferred because it effectively stabilizes the irritated ventricular muscle without significantly slowing down the AV node.
Okay.
Since digoxin itself has a major negative chronotropic effect and can cause AV block, using other antiarrhythmics that also severely depress the AV node could push the patient from an arrhythmia crisis into a complete heart block crisis. Lidocaine offers the best balance of efficacy and safety in this specific scenario.
Excellent. And to help you synthesize this massive amount of drug information, let's revisit the mnemonics toolkit one last time.
For the cornerstone RAS inhibitors, the prils are the ACE inhibitors, chilpril, and the sartans are the ARBs. The Spartan blocks the receptor
Right.
for the functional pillars of management. The Ds, diet, diuretics, dilators, digoxin, dopamine. And most importantly, remember the 4 classes proven to save lives: ACE-IRBs, beta blockers, aldosterone antagonists, and the ARNI.
What a detailed and powerful exploration. We move from the simple analogy of a failing pump to the most advanced combinatorial chemical warfare against the body's own detrimental survival instincts.
The crucial takeaway, after absorbing all this detail, is that CCF is a progressive chronic disease fueled by the body's overreaction to low output. We have to be aggressive in blocking the RAS and sympathetic nervous systems with the mortality reducers at the VIPs, while providing mechanical relief through volume control with diuretics and selectively boosting contractility with inotropes.
It's that layered approach.
This layered approach ensures the patient not only feels better today, but has a chance at a much longer, healthier future.
That emphasis on long-term survival is the key difference. And since we discussed how heart failure involves the heart muscle thickening and becoming stiff due to this pathological remodeling, scarring, or fibrosis, here is a final thought for you to explore. If we can block the hormonal signals that cause the scarring, how might new future therapies that target the actual collagen matrix or the stiffness itself, specifically anti-fibrotic drugs, further change the future of CCF management, moving beyond pressure and volume control? So let's start at the very beginning with the perfect symphony.
All right, so coming to the next slide. To really understand the chaos of an arrhythmia, we first have to appreciate the perfection of the normal beat.
Exactly.
Our source material gives us this beautiful analogy. The heart's electrical system operating as a perfectly tuned orchestra. Every musician, every instrument has to play its part exactly on time.
And that perfect tuning starts with the master timer, the conductor, which is the sinoatrial node, or SA node for short.
The SA.
The SA node is the heart's natural pacemaker. It's made of these specialized cells that just automatically fire an electrical impulse, and that sets the foundational pace for the entire heart.
It's the conductor raising the baton for that first defining note.
That's a perfect way to put it.
So once that impulse is initiated, it can't just spread randomly through the heart, right? It has to travel along a very precise highway.
A very specific path. It starts in the upper chambers, the atria, which causes them to contract.
Okay.
And then it immediately hits the most critical gateway in the whole system, the atrioventricular node, or AV node.
An E node, and this is the rhythm guard, as the slide calls it.
It truly is the rhythm guard. If you think about the physics of pumping blood, you need the atria to contract first to completely fill the ventricles.
Right, to get all the blood in there before the big squeeze.
Exactly. So the AV node steps in, and it intentionally slows down the electrical signal. It puts in this momentary delay, like a brief, necessary pause in the music.
It's quality control for cardiac output.
It is. It ensures the ventricles have enough time to receive all the blood before they're told to contract. Without that slowdown, the heart would just be beating too fast to be efficient.
So once it's past the AV node, the impulse needs to spread really fast.
Super fast. It screams down the bundle of his, then branches out quickly through the bundle branches, and then it reaches the deep muscle via the Purkinje fibers.
And that's the signal for the ventricles to contract forcefully.
Right. And when this entire process is executed flawlessly, from the SA node firing, through the AV node's delay, and the Purkinje's rapid distribution, the result is what we call sinus rhythm.
Sinus rhythm.
That's the normal rhythmic contraction driven by the SA node. That is the harmony, the perfect, predictable music we're always trying to restore.
So we have the ideal rhythm. Now let's go to the next slide, which asks, what happens when that electrical system breaks down?
When the music becomes discordant.
Right. And that failure is, clinically, an arrhythmia.
An arrhythmia is simply defined as Any disturbance in the cardiac rhythm. It could be a failure in where the impulse starts, how fast it fires, how regular it is.
Or how well it conducts through that precise pathway we just talked about.
Exactly. And we can relate these disturbances right back to our musical malfunctions analogy.
So if the beat is rushing too fast for the heart to work efficiently, that's tachycardia. The tempo has suddenly just accelerated out of control.
And if the rhythm drags too slow, that's bradycardia.
And then there's the most dangerous type where all synchronization is just lost.
Right. The chaotic jam session where everyone's playing a different rogue tune, that's fibrillation. The electrical signals are so disorganized that the muscle just quivers instead of contracting effectively.
It's not pumping anything at that point.
Nothing. It's an electrical emergency.
The source outlines 3 simple ways this chaos can start, and I think these are really important because they dictate how we treat it. The first one is pretty straightforward. The conductor itself is faulty.
Right, the SA node is firing too fast or too slow, or just irregularly. Simple as that.
The second one is more of a structural failure, what the slide calls a short circuit or a re-entry loop.
This is a huge one. Imagine the electrical signal, after it's passed through the ventricle, finds a little path to loop back and re-stimulate the tissue it just left.
So it's getting caught in a loop.
A self-perpetuating echo effect. It causes the heart to refire prematurely, over and over again. And breaking that short circuit is a major target for antiarrhythmic therapy.
And the third cause is fascinating. The slide calls them the rogue solos.
I love that term. These are spots outside the normal conduction system. We call them ectopic foci, and they develop what we call increased automaticity.
Meaning they just decide to start firing on their own?
They decide they want to be the new conductor, and they're often much faster, generating their own rapid rhythm completely outside the control of the main conductor, the SA node.
So whether it's a faulty conductor, a short circuit, or a rogue solo, all these problems really originate at the cellular level.
Absolutely. Which is why, before we even open the toolkit, we have to zoom way in and understand the precise electrical language of a single heart cell.
Okay, now coming to the next slide. The journey to understanding these drugs absolutely requires us to understand the action potential, or AP. This is the tiny electrical dance that happens inside every single heart cell, every single time the heart beats. And it's a 5-step choreography involving 3 key ions: sodium, potassium, and calcium.
This is the critical foundation. We really have to walk through this in detail like telling a 5-chapter story, because every single drug we discuss later on intervenes in one of these chapters.
Okay, let's do it. Chapter 1, Phase 4, ready and waiting.
This is the cell's resting state, the resting membrane potential. The inside of the cell is highly negative compared to the outside. It's just poised like a camera flash waiting to be charged up.
And the key ions are set up, right? Potassium is mostly inside, and sodium and calcium are waiting outside.
Exactly. Then comes Chapter 2, Phase 0, the ignition. This is the explosion.
The spark.
The signal arrives from the cell next door, and that triggers the opening of these fast-gated sodium channels.
Okay.
And because sodium is so highly concentrated outside, it just rushes massively into the cell.
All that positive charge floods in.
Right. This rapid influx of positive charge causes the cell to depolarize. The internal charge flips from negative to strongly positive. This is the spark, the rapid upstroke, and it's the exact moment a Class I drug tries to control.
And that explosion is immediately followed by a little breather, right? Chapter 3, Phase 1, quick breather.
That's right. The fast sodium channels slam shut almost instantly, and you get this tiny, temporary readjustment. Some potassium might briefly exit, causing a small downward notch in the graph just before the main event stabilizes.
It's just a momentary dip.
A momentary dip before the plateau.
Which brings us to Chapter 4, and this is arguably the most vital for the mechanical function of the heart. Phase 2, the squeeze or the plateau.
This is where the muscle contraction actually happens. It's a critical balancing act. Calcium channels, specifically L-type channels, open up, and calcium flows into the cell.
So more positive charge is coming in.
But it's counterbalanced by the continued outflow of potassium. So you have positive calcium coming in and positive potassium going out. These opposing currents stabilize the charge for a sustained period, and that creates the electrical plateau.
And that plateau is what gives the heart muscle enough time to fully contract and squeeze the blood out.
No plateau, no effective pump. It's that simple.
Okay, and finally, Chapter 5, Phase 3, the reset. The muscle has contracted, and now the cell needs to recharge for the next beat.
The calcium channels close, and the main driver now becomes this massive, unrelenting outward flow of potassium. This huge efflux of positive charge rapidly brings the internal cell potential back down to its negative resting state.
The cell repolarizes.
It repolarizes,
Yeah.
returning to phase 4, ready for the next impulse. And a class 3 drug targets this final reset phase.
So, to just quickly summarize the critical ion movements, phase 0 is sodium in, the ignition.
Yep.
Phase 2 is calcium in, the squeeze.
Huh?
And phase 3 is potassium out, the reset.
You've got it. If the heart gets too rapid, it's usually because one of these phases is happening too quickly, or a rogue cell is, skipping phase 4 and initiating its own beat.
All right, moving to our next slide. Now that we know the electrical blueprint, we can finally talk about the toolkit designed to intervene in that 5-step dance.
Exactly. When phase 0 is too fast or phase 3 is too short, we need a targeted intervention.
And this is where the Vaughan Williams classification becomes our indispensable organizational chart. It's the international standard, and it logically groups all antiarrhythmic drugs based on which ion channel they primarily mess with.
The brilliance of this system is its simplicity. The 4 main classes.
Okay.
Class I drugs are the sodium channel blockers. They act on the ignition, phase 0.
Right.
Class 2 are the beta-adrenergic blockers. They act more on the starting pace in phase 4.
Yeah.
Class 3 are the potassium channel blockers. They act on the reset, phase 3.
Then class 4.
The calcium channel blockers. They act on the plateau, and they're especially important at the nodes.
That structure is crystal clear, and thankfully the source material gives us a fantastic memory hack right away to keep these 4 main classes straight.
It's a great one. Remembering the main ion targets is simple with a mnemonic. No body plays clean.
No body plays clean. So N is for Na plus S sodium, which is class 1.
Right.
B is for beta, class 2. P is for potassium, class 3.
And C is for calcium, class 4.
That single sentence unlocks the entire framework. Okay, so now we can dive into each class in detail. Let's go to the next slide. Let's start with class I, the sodium channel blockers. Their main job is to dampen that explosion of phase 0.
They're called the membrane stabilizing agents. Their story in our orchestra is simple. They slow down the speed of conduction.
How do they do that?
By blocking those fast sodium channels, they reduce the rate of rise during phase 0. This makes the electrical beat less forceful and slower to spread from cell to cell.
So if you have a short circuit, that re-entry loop that depends on fast conduction.
Slowing it down can break the loop. Exactly.
But this is where things get a bit tricky, because class I isn't just one drug. It's a family of drugs, and they're divided into subclasses based on the intensity of their effect.
Correct. You have to think of it as an intensity dial with 3 settings.
Okay.
Class IA drugs cause a moderate depression of phase 0. These are drugs like quinidine, procainamide, and disopyramide. They slow conduction, but they also have some other effects, like lengthening the action potential a bit.
Okay, moderate. What's next?
Class IB. This group has a minimal effect on phase 0, and they often actually shorten the action potential. These are lignocaine and mexilytin.
Okay, so IA is moderate, IB is minimal, which leaves IC.
And Class IC drugs cause a marked depression of phase 0. These are the strongest blockers. Flecainide and propafenine. They slow conduction profoundly.
Wow, that is an intimidating list to just memorize. And the source material was brilliant in providing the necessary hack for this. Let's bring in the mnemonic.
Yeah, this one is a lifesaver. The trick is, quiet please, don't laugh much, for Pete's sake.
Okay, let me try this. Quiet, please don't. That gives us QPD for class IA, quinidine, procainamide, disopyramide.
You got it.
Laugh much. That's LM for class IB. Lignocaine, mexilytin,
Perfect.
and for Pete's sake is FP for class IC. Flecainide, propafenone, that actually works really well.
It does. But before we spotlight lignocaine, we have to mention a really critical clinical warning about those class IC drugs, flecainide and propafenone.
The ones that cause marked depression.
Exactly. Because they slow conduction so profoundly, they carry a very significant risk of what we call proarrhythmia.
Meaning they can cause a new arrhythmia.
A new and potentially fatal arrhythmia. This is especially true in patients who already have structural heart disease, like a previous heart attack or severe heart failure.
So you might fix the original rhythm problem, but you risk creating an even worse one by slowing the underlying rhythm too much.
It's a huge risk. It means the doctor has to be absolutely certain about the patient's heart structure before ever prescribing a class IC agent.
That brings us to our next slide and our first major drug spotlight, lignocaine. It's a class IB drug, and the slide calls it the emergency responder.
Lignocaine is a really specialized tool. Unlike the others, its primary mechanism involves preferentially blocking sodium channels that are in the inactivated state.
Okay, what does that mean, the inactivated state?
Well, after the cell fires in phase 0, those sodium channels quickly move into an inactivated state before they can reset back to the resting state in phase 4.
So why does targeting that specific state make it an emergency responder?
Because damaged, sick heart tissue, the tissue that's low on oxygen after a heart attack, what we call ischemic tissue, or tissue that's firing way too rapidly in a ventricular arrhythmia, that tissue spends much more time with its sodium channels stuck in that inactivated state.
I see.
So lignocaine is brilliant because it finds the sick, overworking cells and it silences them, while pretty much leaving the healthy, resting cells alone.
It's a targeted strike.
The ultimate targeted strike for ventricular stability.
Okay, so that immediately brings up a point that I think is really important. If lignocaine relies on those channels being inactivated for a long time, what does that tell us about using it in the atria, the top chambers?
Exactly. We know the action potential in atrial cells is much, much shorter than in ventricular cells.
So the channels aren't in that inactivated state for very long?
Precisely. The atrial action potential is so short, the sodium channels move through that inactivated state extremely quickly, giving lignocaine almost no time to bind effectively.
So lignocaine is essentially useless for treating atrial arrhythmias, like AFib. The cellular mechanism predetermines its clinical failure. That's a huge takeaway.
It's a fundamental point. Clinically, lignocaine is the absolute go-to for emergency treatment of ventricular arrhythmias associated with a heart attack, or digitalis toxicity, or right after cardiac surgery.
But we have to talk about the administration hack, which is a big deal.
It is. It must be given intravenously.
Why can't we just take it as a pill?
Because lignocaine undergoes what's called extensive first-pass metabolism in the liver. If you swallow it, the liver just destroys the vast majority of the drug before it can ever reach the heart.
So to make it work, it has to be an IV bolus, followed by a continuous infusion.
Right. And because we're infusing it, often in an emergency, we have to watch the side effects very closely, particularly those affecting the brain, because it crosses the blood-brain barrier so easily.
So the toxicity is neurological.
Almost entirely. You'll see drowsiness, confusion, unusual muscle twitching, nystagmus, that's the involuntary rapid eye movement, and in severe cases, you can even get seizures.
So you have to monitor the patient's mental status just as closely as you're watching the heart monitor?
Absolutely.
Let's picture that ER scenario again. A patient has a heart attack and suddenly their heart goes into ventricular tachycardia.
A life-threatening rhythm.
The team immediately pushes lignocaine the fourth. You're using a drug that seeks out only the damaged, stressed cells and silences their erratic firing, buying crucial time to stabilize the patient.
It's a literal electrical ceasefire.
Yeah. Okay, on to the next slide. Having covered the ignition, we now shift our focus to controlling the heart's overall pace. This brings us to class 2 drugs, the beta-adrenergic blockers, or just beta blockers.
Right. We're moving away from directly blocking the ion channels in phase 0, and we're focusing instead on hormonal input.
The analogy here is shielding the heart from stress hormones.
Exactly. They act as a protective shield against catecholamines, adrenaline, and noradrenaline. When you're stressed, those hormones tell the SA node, our conductor, to speed everything up.
And beta blockers step in and say, not so fast.
They tell the conductor to calm down and maintain a steady, lower tempo, no matter what the patient's stress level is.
So what's the cellular mechanism that achieves that calmness?
They depress the slope of phase 4 depolarization. Remember, phase 4 is that resting phase where the pacemaker cells gradually drift upward toward their firing threshold.
Right.
By dampening the effect of adrenaline, the beta blockers slow that upward drift. It takes much longer to hit the firing threshold.
So the end result is just a slower heart rate.
A decrease in automaticity and a slower heart rate. Yes.
Okay, we have several key players here. There's propranolol, which is non-selective. What does that mean?
It means it blocks both beta-1 receptors, which are in the heart, and beta-2 receptors, which are in the lungs and other places.
Which can cause problems in people with asthma.
It can, which is why we more commonly use the cardioselective agents, which primarily targets the beta-1 receptors in the heart.
And those are metoprolol, atenolol, and esmolol.
Correct. And we had to mention that unique exception again, sotalol. It's a beta blocker, so it's class 2, but it also has significant class 3 activity. It's a multi-talented agent.
The hack for remembering these is so simple, it's almost funny. Just look for the common ending. The drugs that end in olols are the ones that make the heart rate less.
It works every time. And let's spotlight esmolol for a second, which is nicknamed the Sprinter.
Why the Sprinter?
Because it has a super rapid onset and, crucially, a very short half-life. It's out of the system very quickly.
So it's good for emergencies when you need precise control.
Perfect for fee use when you need immediate rate control for something like atrial fibrillation or flutter, but you need to be able to reverse the effect or switch to an oral drug quickly.
All right, next slide. Now we're going to target the third key ion, potassium. This is class 3, the potassium channel blockers. If class I hit phase 0, the ignition, and class 2 hit phase 4, the pace, class 3 is all about regulating phase 3, the reset.
This is where we break those reentry loops we talked about. The mechanism is to block the potassium channels that are responsible for that massive outward flow during phase 3.
And by blocking them, you dramatically prolong the action potential duration, or APD.
Right. You're keeping the cell electrically positive for longer, delaying its return to the resting state.
So why is that delay so critical for stopping arrhythmias?
It directly prolongs the effective refractory period, or ERP.
Okay, what's that?
Think of the ERP as the period during which the heart tissue is absolutely unexcitable. Doesn't matter how many rogue electrical signals hit it, it simply cannot respond.
It's like a do not disturb sign is up.
A mandatory one. If a cell is repolarizing too quickly, its ERP is short, and that leaves a little window open for a short-circuit impulse to find a path and refire the tissue prematurely.
I see. So by extending the ERP, you are essentially adding a long mandatory rest note to the sheet music.
Exactly.
And that rest note is longer than the time it takes for a short-circuit impulse to arrive, guaranteeing that when the impulse does arrive, the cell is still refractory and just ignores it.
You break the loop. You lengthen the duration of that electrical unavailability. These are powerful drugs used to maintain sinus rhythm in conditions like AFib.
Okay, and the key players are some pretty strong ones. Amiodarone, sotalol, dofetilide, butylide, and bertelium.
It's another complex list.
And thankfully, another memorable trick to lock these K-plus blockers in place.
Indeed. We can use the mnemonic. A big dog is scary.
A big dog is scary. Okay. A is for amiodarone, B is for bertelium, dog for dofetilide is for abutylide.
And scary for sotalol.
Perfect. That covers the entire class, linking the drug name to the specific ion it blocks.
Now, coming to the next slide, we arrive at the most complex, most effective, and honestly, most feared drug in the entire antiarrhythmic toolkit, amiodarone.
We call it the Swiss Army knife.
For a very good reason.
It's chemically loaded with a significant amount of iodine. And while its main classification is class 3, the reason it works on almost any arrhythmia is that it truly does it all.
It's a polychannel blocker. Yes, its main job is blocking potassium channels, that's its class 3 action, but it also has significant blocking effects on sodium channels, that's class 1. It acts as a beta blocker, that's class 2, and it even blocks calcium channels, that's class 4.
So it's a broad-spectrum rhythm stabilizer that can tackle pretty much any kind of electrical discord, whether it's atrial or ventricular.
It's highly effective for maintaining normal rhythm in both severe AFib and dangerous ventricular tachycardia. But its versatility comes at a massive cost, which we absolutely have to detail.
And it starts with its pharmacology.
It does. The biggest clinical problem here is its extremely prolonged half-life. It can be anywhere from 1 to 2 months.
Months, not hours or days.
Months. This means that amiodarone accumulates in tissues all over the body. And if a patient develops a severe side effect, that toxicity will stick around for months after they stop taking the drug, while the body just slowly clears it.
That is a staggering implication.
Yeah.
You mentioned it affects almost every organ system. We need to detail these side effects because they're so critical for monitoring.
We have to. Let's visualize that multi-tool and link its dangers to specific organ systems.
Mm-hmm.
First, the lungs. This is maybe the most serious one. Pulmonary fibrosis.
That sounds really bad.
It's irreversible scarring of the lung tissue. It shows up as a persistent dry cough and shortness of breath.
Okay, what's next?
The thyroid. Because it's loaded with iodine, amiodarone can cause either hypothyroidism and underactive thyroid or hyperthyroidism and overactive one.
Then the eyes. The slide mentions corneal deposits.
Right. Patients often develop these benign corneal deposits. They can cause halos or blurred vision, but they typically don't require stopping the drug. They're just there.
Okay, and the skin.
It causes photosensitivity, so patients can get severe sunburns very easily.
Hmm.
And long-term use can lead to this distinctive, unusual blue-gray pigmentation of the skin.
And we still have 2 more. The liver and the nerves.
Right. We have to monitor liver function tests very carefully because there's a risk of hepatitis or hepatotoxicity. And finally, the nerves, where it can cause peripheral neuropathy, leading to tingling or weakness in the hands and feet.
6 major diverse organ systems. It really underscores why amiodarone, despite how effective it is not a first-line therapy for minor arrhythmia.
Absolutely not. It's reserved for when the electrical fire is serious enough to warrant using a tool with such pervasive systemic risk. The patient is essentially committing to a long-term monitoring regimen just to manage the drug itself.
All right, on to the next slide. After the class 1, 2, and 3 drugs, we complete the von Williams framework with class 4. These are the calcium channel blockers, which the slide calls the gatekeepers.
And we're specifically talking about the non-dihydropyridines here, verapamil and diltiazem. We know calcium is vital for phase 2, the plateau and the squeeze.
Right.
They block L-type calcium channels. But their primary clinical focus is on the electrical system's decision makers, the SA and AV nodes.
Why there specifically?
Because in those nodal cells, calcium influx is the main driver of phase 0 depolarization, not sodium. So by blocking calcium channels, these drugs profoundly slow conduction velocity and increase the refractory period, specifically within the AV node.
So if the atria are racing chaotically, like an AFib, these drugs act like a gatekeeper and make sure that not all those rapid signals can get through the AV node to the ventricles.
Exactly. They're perfect for rate control, keeping the ventricle from racing too fast.
Okay, so now, outside of the 4 main classes, we have 2 essential specialists that don't fit the structure but are paramount clinically. First, adenosine, the reset button.
This drug is dramatic.
You mentioned it causes a temporary pause. What is its mechanism?
Adenosine activates specific receptors on the cell surface, and this activation massively increases potassium conductance. Basically, it causes the potassium channels to fly open and flood out of the cell, leading to extreme hyperpolarization of the AV nodal cells.
Hyperpolarization, so the cell's internal charge becomes even more negative than its normal resting state.
Correct. And if the cell is hyperpolarized, it becomes profoundly difficult to excite. Clinically, this shows up as a near-instantaneous temporary electrical block in the AV node, a total system pause.
And its primary use is for what?
Rapid termination of paroxysmal supraventricular tachycardia, or PSVT, which are usually caused by a rapid reentry loop involving that AV node.
And the key fact is its duration, right?
Yes, an extremely short duration of action, less than 1 minute. You give the drug fast IV push, the heart pauses, the reentry loop is broken, and hopefully the normal SA node takes over again.
It's a chemical hard reset.
It is, often with the clinical drama of a patient briefly feeling like their heart is completely stopped before the rhythm stabilizes.
Wow. Okay, and the second specialist is digoxin, the rate controller.
Digoxin is a bit different. It works by enhancing the activity of the vagus nerve, which is the body's natural electrical brake. By increasing this vagal tone, it slows conduction through the AV node.
So it's another way to control the rate.
Exactly. Digoxin is primarily used to control the ventricular rate in chronic conditions like atrial fibrillation, especially if the patient also has coexisting heart failure. It just helps keep the rhythm slow enough to let the ventricles fill properly.
Okay, now coming to the next slide. We've assembled the full toolkit. We have Class I hitting Phase 0, Class 2 hitting Phase 4, Class 3 on Phase 3, and Class 4 and the specialist hitting the AV node. The next critical step is linking the specific arrhythmia to the specific tool.
Right. The clinical goal dictates the choice. Are we trying to slow the rate down rate control? Or are we trying to shock the heart back into its perfect sinus rhythm control?
Let's run through the table on the slide. For paroxysmal supraventricular tachycardia, PSVT, that rapid short circuit above the ventricles, what is the clear first choice?
Adenosine is the gold standard for rapid termination because of its efficacy in that super short duration. Alternatives would be the rate controllers, verapamil, which is class 4, or esmolol, which is class 2.
Okay, now moving to the really common atrial rhythms, atrial fibrillation, the chaotic one, and atrial flutter, the more organized, rapid one.
For both, we often use broad-spectrum agents or strong rate controllers. Amiodarone, the Swiss Army knife, is highly effective for converting the rhythm.
Right.
Verapamil and esmolol are excellent for simple rate control. Propofanomy, the class IC drug, can be used for rhythm restoration, but only in patients without structural heart disease.
And digoxin.
And digoxin is used for chronic rate control, particularly if there's heart failure.
Okay. Now for the really dangerous ventricular rhythms. For ventricular tachycardia, VT, what stabilizes the system?
There we rely on the broad power of amiodarone and the general beta blockade from propranolol. These are high-stakes situations that require a really strong antiarrhythmic effect.
And finally, the ultimate electrical chaos. Ventricular fibrillation, VF, where the heart is just quivering and circulation has stopped.
Here, the goal is immediate electrical stabilization right after defibrillation.
Huh.
And we return to our emergency responders, amiodarone and lignocaine.
We use lignocaine specifically because of its ability to target and stabilize that damaged, rapidly firing ventricular tissue that's so common in VF settings.
Just as we discussed earlier, the consistent link is fascinating. When the problem is acute and in the ventricle, lignocaine is invaluable.
And when the problem is chronic or requires a profound rhythm conversion anywhere in the heart, amiodarone is often the answer, despite all that toxicity.
All right, now coming to the next slide. We've absorbed an immense amount of chemistry and clinical application. The next vital step is to consolidate the hacks you were provided to make sure this complex information is locked in and immediately accessible.
Let's run through them one last time, starting with the foundation, the 4 classes.
Nobody Plays Clean gives us N for sodium, class 1, B for beta, class 2, P for potassium, class 3, and C for calcium, class 4. That is the master key.
Then that often confusing breakdown of the sodium blockers by intensity. We use the full sentence for that one.
Quiet, please. Don't laugh much for Pete's sake. It links IA, IB, and IC to their respective drugs, QPD, LM, and FP.
The easiest hack is next, the beta blockers. Just look for the suffix, the olols, that make the heart rate less.
And our powerful class 3 potassium blockers. A big dog is scary.
Amiodarone, beryllium, dofetilide, abutylide, sotalol.
Perfect.
Finally, we have to lock in that extensive risk profile of amiodarone, the Swiss Army knife.
You visualize the multi-tool affecting the whole body. You link the organ systems to the risk. Lungs and pulmonary fibrosis, thyroid and hyperthyroidism, eyes and corneal deposits.
Skin with photosensitivity and that blue-gray color, liver with hepatotoxicity, and nerves with peripheral neuropathy. That list requires constant vigilance.
It really does. And since we highlighted adenosine as that dramatic reset button, let's just quickly revisit the immediate acute side effects, which can feel terrifying to the patient.
This is the adenosine ABCs.
Exactly. A is for asystole, the pause itself. B for bronchospasm. C for chest pain. D for dyspnea, or shortness of breath.
Okay.
E for expensive, which it is. F for flushing. G for hypotension, that transient low blood pressure. And H for headache. They're short-lived, but they are intense.
All right, next slide. We've reached the final test of synthesis. Let's run through these questions, connecting the cellular mechanism directly to the clinical result.
Let's do it. Question 1, basic science. What ion is primarily responsible for the rapid ignition of phase 0 in a ventricular action potential?
That is the initial surge of positive charge that flips the cell potential. That has to be sodium Na+.
Correct. Question 2, mechanism. Which drug class works by prolonging phase 3 of the action potential to delay the cell's reset, thereby extending the effective refractory period?
That delay, that extended rest period designed to break re-entry loops, that is the core function of the class 3 potassium K+ channel blockers.
Perfect. Question 3, clinical choice. A patient in the ER presents with PSVT. What is the preferred drug for rapid termination and why?
The gold standard for rapid termination is adenosine, and the why is because of its high efficacy in inducing that temporary AV nodal block combined with its crucial, super short duration of action.
Exactly. Less than a minute. Okay, question 4, adverse effects. A patient on long-term amiodarone therapy develops a persistent dry cough and shortness of breath. What serious side effect is a major concern, and why is the long half-life so relevant here?
That symptom set is the classic red flag for the most feared non-cardiac toxicity, pulmonary fibrosis. And the long half-life is relevant because even if you stop the drug immediately, the toxicity will continue and may even worsen for weeks or months as the drug slowly leaves the tissue.
A critical point. And finally, the advanced application question that ties mechanism to clinical failure. Question 5. Why is lignocaine the drug of choice for ventricular arrhythmias after a heart attack, but generally useless in healthy atrial tissue?
The answer is all in its unique targeting. Lignocaine preferentially binds to sodium channels in the inactivated state.
Right.
Ischemic or rapidly firing ventricular tissue has an abundance of these channels, making it a perfect specific target. But healthy atrial tissue moves its channels through that state way too quickly for lignocaine to bind effectively, making it useless for atrial rhythms but perfect for ventricular emergencies. And now coming to our last slide. That concludes our deep dive into the heart's electrical symphony and the pharmacology designed to restore harmony when the music goes wrong.
We've really moved from understanding the molecular physics of ion movement to mastering the complex von Williams toolkit.
Yeah.
The core lesson is that every single one of these drugs is chosen precisely because of its mechanism, whether it's dampening the ignition, slowing the pace, or forcing a longer rest node.
And we saw the immense power and utility of a drug like amiodarone, but that multi-tool functionality comes at an astronomical cost of monitoring and widespread systemic risk.
It forces a constant negotiation between efficacy and safety, especially with that months-long half-life hanging over everything.
So here is a final provocative thought for you to carry forward. We know amiodarone works because it hits every channel class 1, 2, 3, and 4. The future challenge for pharmaceutical design isn't making a drug more potent, but making one that is perfectly channel selective. Could bioengineering or new targeted drug delivery systems be developed that restrict the amiodarone molecule, or maybe a new derivative of it, only to the cardiac tissue? Could we prevent its systemic accumulation in the thyroid, the lungs, and the liver, and thus give us the power of the Swiss Army knife without the crippling systemic side effects?
That is a fascinating challenge and one that will define the next era of cardiology. Thank you for joining us on this in-depth exploration of the heart's electrical complexity.
We'll see you next time. Why does a doctor choose one drug over another? What internal fact through line is that drug actually targeting?
Exactly. This is about deep understanding, not just rote memorization.
That's the goal.
I love that framing. So let's start at the very beginning. Let's introduce the players. Before we can even talk about the drugs, we have to meet the characters they're designed to fight for and against.
Okay, so now coming to the next slide, here we get to meet our main characters.
And who are they?
The two main characters in our story are cholesterol and triglycerides, or TGs, as we'll probably call them.
People often just lump them together as fat, but they're completely different things, aren't they?
Completely separate. And they play entirely different and equally crucial roles in the body.
Okay, so let's start with cholesterol. The simple story, the foundational analogy here, is that cholesterol is the bricks and mortar for the body. It's absolutely essential.
It's the structural master. I mean,
Yeah.
cholesterol is this waxy, fat-like substance that gives integrity to every single one of your billions of cell membranes.
Every single one.
Every single one. If you think of a cell wall like a tent, cholesterol would be the critical poles and the reinforcing cables. It provides stability, it controls what gets in and out.
So it lets the cell function correctly.
Exactly. Without it, the whole structure collapses.
And the advanced detail here just confirms how indispensable it is. It's not just structural support, is it? It's the precursor molecule. I mean, it's the starting block for some of the most powerful agents in the body.
Absolutely. We're talking about hormones. Steroid hormones like cortisol, testosterone, estrogen. They all start from cholesterol.
Wow.
And critically, vitamin D synthesis relies on cholesterol. Plus, you need it to produce bile acids, which are like these specialized detergents your body uses to digest the fats you eat.
So if your body's cholesterol factory just shut down entirely.
You'd have systemic failure. It's that simple. The problem isn't cholesterol itself. It's always about excess delivery and inefficient clearance.
Okay, that makes perfect sense. Which brings us to our second character, triglycerides, or TGs. Totally different function. We call them the body's reserve fuel tank.
And that's exactly what they are. They're purely for energy storage. TGs are the most common type of fat, and the mechanism is, well, it's elegant. When you eat more energy, more calories than your body needs right now, that excess is chemically converted into triglycerides. These TGs are then bundled up and stored in your adipocytes, your fat cells.
So it's like a bank account, right? Cholesterol is the cash you need in your wallet every day for transactions, for building things. Triglycerides are like the long-term savings bond.
Perfect analogy. It's designed to be broken down later when you need that sustained energy, like during fasting or exercise.
And that leads us directly to the big transport problem. We have these crucial fat-based molecules that need to get around the body, but our bloodstream is, well, it's mostly water.
It's the classic oil and water don't mix challenge.
So now coming to the next slide, we can see how the body solves this. How do these hydrophobic or water-hating passengers navigate the watery highway of our circulatory system?
The body developed a brilliant solution. Lipoproteins. We call them the delivery trucks, or specialized molecular buses.
Delivery trucks, I like that.
And these structures have a fat-based core, which carries the cholesterol and TGs, and then a water-soluble shell made of proteins and phospholipids. That shell lets them float comfortably in the blood.
And within this fleet of trucks, we have the family members that we hear about all the time in, our checkups. Let's start with the notorious one, LDL, low-density lipoprotein. We've all heard it branded as the bad cholesterol.
Right, and LDL's job isn't inherently bad. Not at all. It's the primary delivery vehicle. It takes cholesterol from the liver and drops it off to all the tissues that need it for cell repair or making those hormones we talked about.
But the problem comes when there are too many of these LDL trucks, right? You get traffic jams, they start crashing. Or, more accurately, they start dumping their cargo inside the artery walls.
And that's the genesis of cardiovascular disease. The more LDL trucks you have on the road, the higher the risk of those foundational blockages forming.
Okay, so if LDL is the bad guy, then we have the hero of the transport system. HDL, high-density lipoprotein. We call this one the garbage truck.
The cleanup crew. It's a very accurate name.
What makes it so good?
HDL performs something called reverse cholesterol transport. It's the only lipoprotein designed specifically to go out and pick up excess stray cholesterol from the peripheral tissues.
So from those fatty deposits that are forming in the artery walls.
Exactly. It picks them up and ferries it back to the liver. Once it's in the liver, that cholesterol can be processed, repackaged, or just excreted from the body through bile.
So the higher your HDL, generally, the more efficiently your system is being cleaned.
That's the idea. And we also have VLDL, very low-density lipoprotein. This truck is different again. It primarily carries that reserve fuel, the triglycerides, from the liver out to the fat cells.
And what's the connection to LDL?
Well, as VLDL delivers its cargo of triglycerides, it shrinks. And it eventually transforms first into an intermediate form and then sometimes into the bad guy, LDL. So high VLDL and high triglycerides are very connected to your overall LDL risk.
It's all one big interconnected system. And since these are the targets the drugs are aiming for, we have to establish the normal ranges, the numbers your doctor is looking at.
Right. These are measured in milligrams per deciliter, or mgdl. For total cholesterol, you want to be less than 200. For the bad one, LDL, the target is less than 100. For HDL, the protective one, it should be greater than 40 for men and a little higher, greater than 50 for women.
And what about triglycerides, the fuel reserve?
You want to keep that below 150. Those are the key benchmarks.
And when those numbers are out of balance, especially when that bad cholesterol is high, we confront the villain of our story.
Now, coming to the next slide. The villain. Hyperlipidemia. It's the medical term for having too many lipids in the blood, cholesterol, triglycerides, or both. And the danger this villain brings is profound. It's called atherosclerosis.
If you look at the comparison in the source material between a healthy artery and one with atherosclerosis, the contrast is it's stark. The excess LDL gets into the artery wall, it gets oxidized, it triggers inflammation, and it starts building up this stuff called plaque.
We use the analogy of rust building up inside a pipe. That plaque is a hard, waxy, yellow substance. It narrows the artery, which restricts blood flow. But the real danger isn't the narrowing, it's the stability of that plaque.
What do you mean by stability?
The plaque can just sit there for years. But if the fibrous cap covering it ruptures, like a crack suddenly appearing in the rust, the body sees that as a catastrophic injury.
And the immediate devastating consequence is a blood clot.
Yes. The body tries to patch the rupture by forming a clot. If that clot completely blocks the already narrowed vessel, you get an acute event.
A heart attack if it's in a coronary artery, or a stroke if it's in an artery in the brain.
Precisely. This is why managing hyperlipidemia is the absolute cornerstone of cardiovascular risk prevention.
So this raises a really important clinical question. Why does this villain appear in the first place? How do we classify the causes?
We classify them as primary and secondary. Primary hyperlipidemia is largely genetic. This means a person's body, due to inherited factors, either overproduces lipids or it just lacks the machinery to clear them effectively from the blood.
And this can show up early in life, can it?
Yes, often leading to very high cholesterol levels from a young age. Then you have the more common group, secondary hyperlipidemia, which is acquired.
So this is caused by other health conditions or external factors that mess up your normal lipid metabolism. We're talking about things that create, well, metabolic chaos.
Think of diabetes mellitus. Uncontrolled diabetes leads to a huge increase in the production of VLDL, those triglyceride carriers, by the liver.
Right.
Or hypothyroidism, where a sluggish thyroid gland slows down the clearance of LDL from the blood.
Chronic renal disease is another big one.
And it's crucial for listeners to know that lifestyle and even other medications can contribute. Chronic alcoholism, for instance, dramatically increases triglyceride production.
And the source material lists specific drug classes that can cause this.
It does. We have to mention beta blockers, corticosteroids, and oral contraceptives. They can all interfere with different parts of the metabolic cascade and worsen a patient's lipid profile.
Which really highlights why a clinician never just treats the numbers in isolation, They have to look at the whole patient, all their conditions, all the medications they're taking.
Absolutely, the full picture is everything.
Okay, so now that we understand the anatomy of the disease and the players involved, let's pivot and meet the heroes. Let's look at our arsenal, the strategies we use to fight back.
Right. Now, coming to the next slide. Here we have our arsenal. We've got a comprehensive set of tools categorized into 5 main classes of lipid-lowering drugs, each with a completely unique approach.
And we're going to drill down into each of these mechanisms. We have the statins, which are the production blockers,
We have the bile acid-binding resins, the excretion enhancers,
the fibrates, which we're calling the triglyceride tamers,
niacin, the HDL booster,
and finally, a group of inhibitors of cholesterol absorption and more. These are our gatekeepers and our new age warriors.
and this tactical diversity is what makes modern treatment so effective. We have options.
So let's start with the undisputed superstars, the most commonly prescribed class in the world.
Now coming to the next slide, we are talking about the statins. Stopping cholesterol at the source.
Okay, let's unpack their powerful mechanism of action. The key concept here is that most of the cholesterol in your blood, maybe up to 75%, is made inside your body by your liver. It's not just from the food you eat.
Right, the liver is the cholesterol factory.
And statins are designed to shut down the most critical machine in that factory.
They competitively inhibit an enzyme called HMG-CoA reductase. And this isn't just any enzyme. It is the rate-limiting enzyme in cholesterol biosynthesis.
Meaning what exactly? Rate limiting.
It means this one single step where HMG-CoA is converted into mevalonate controls the pace of the entire process. If you block this step, you choke off the entire supply chain dramatically.
But here's where the mechanism gets really powerful. It's the downstream effect, right? Just blocking production is only half the story.
That's the truly brilliant part. When the liver senses that its internal cholesterol pool is rapidly decreasing because of the statin, it initiates a critical compensation mechanism. It panics a little.
A negative feedback loop.
Exactly. The liver cells perceive a deficit, and they react by dramatically increasing the number of LDL receptors on their surface.
And this is the genius of the drug. Those LDL receptors are the powerful vacuum cleaners we mentioned earlier. So by multiplying the number of these vacuums, the liver starts actively pulling more and more LDL cholesterol out of the bloodstream.
It's trying to replenish its own internal supply.
So the clinical result is just outstanding. You get a dramatic and sustained lowering of plasma LDL levels.
It's a two-way win. The drug inhibits the production of new cholesterol, and it supercharges the clearance of the cholesterol that's already circulating in your blood. That's why statins are so effective.
Okay, so let's look at the family tree. Now, coming to the next slide, we can see the whole statin family. And they aren't all interchangeable.
No, they're not. And we need a mnemonic here, a hack for remembering the 6 main players.
I love a good mnemonic.
The one I use is Pravin and Roshan love simple pizza.
Pravin and Roshan love simple pizza.
Okay, that gives us pravastatin, atorvastatin, rosuvastatin, lovastatin, simvastatin, and pitavastatin.
And knowing their potency is key for clinical decisions.
It is. We categorize them. The high-potency statins, the big guns, are atorvastatin, which you might know as Lipitor, and rosuvastatin, or Crestor. These two have a long half-life.
Meaning they stay active in the body longer.
Right, which gives you dosing flexibility. Patients can take them anytime during the day, and they still work well. We also include pitavastatin in this high-potency group. It's actually the most potent statin on a milligram-for-milligram basis.
Wow. Then you have the moderate potency group.
Here we find simvastatin and lovastatin. And what's fascinating here is the pharmacology. Both of these are prodrugs.
What exactly does that mean, a prodrug?
It means the compound you swallow is actually inactive. It has to pass through the liver the first time to be chemically activated into its working form.
Why design a drug like that?
It's often used to improve how much of the drug gets absorbed, or to make sure it gets activated precisely where it's needed most, in this case, the liver.
That's a great piece of detail. And the last one in this group is pravastatin.
Right. Also moderate potency, but it's often chosen because it has a lower risk of drug interactions compared to some of the others, like simvastatin. So it can be a safer choice for complex patients on many medications.
The primary use is undeniable. Statins are the foundation for managing high LDL. But you mentioned bonus benefits, pleiotropic effects.
Yes. The bonus is that they also stabilize existing plaque. They don't necessarily dissolve the rust, but they put a strong protective shell over it, making it much less likely to rupture.
So less likely to cause that dangerous clot.
Exactly. And they have systemic anti-inflammatory actions. All of these factors contribute to their proven cardioprotective effects.
Okay, now coming to the next slide. Every hero has a weakness. We have to talk about the side effects of statins.
And we have a handy mnemonic for this too, based on the enzyme they block. Just remember HMG.
HMG. Okay, let's start with H, hepatotoxicity, liver toxicity.
This is a dose-related issue where we can see an increase in serum transaminase levels. These are liver enzymes that signal damage.
So this is why doctors do routine blood tests.
Exactly. Routine monitoring of liver function tests, LFTs, is mandatory, usually before starting and then periodically after. While severe liver damage is rare, the dose might need to be adjusted if those enzymes climb too high.
Okay, moving to M myopathy. This is probably the most famous and feared side effect. Muscle pain, weakness, tenderness.
And while it's often mild, in rare cases, especially at higher doses or in combination with other drugs, it can lead to a condition called rhabdomyolysis.
Rhabdomyolysis, that sounds serious.
It is. It's a catastrophic breakdown of muscle tissue. This releases muscle components into the blood, particularly a protein called myoglobin, which can cause acute kidney failure. Clinically, any unexplained persistent muscle pain in a patient on a statin is a red flag. It must be investigated immediately.
Okay, and finally, G, gastrointestinal issues.
Right. These are generally more minor annoyances: nausea, vomiting, diarrhea, things like that.
We have to stress two critical safety points here. The first one is in the source material. Statins are contraindicated in pregnancy.
Absolutely non-negotiable. That's because cholesterol is so essential for fetal development. And second, drug interactions are critical. Anything that inhibits a specific liver enzyme called CYP3A4.
Which metabolizes many of the statins.
Right, like simvastatin and lovastatin. Anything that inhibits that enzyme will cause the statin concentration in the blood to increase dramatically.
Which means a much higher risk of that rhabdomyolysis we just talked about.
A much higher risk. The slides list things like cyclosporine, erythromycin, azole antifungals. But even something as common as grapefruit juice can inhibit that enzyme and cause clinically significant increases in statin levels. Patient education is key.
So we've covered the production blockers, but what if we want to tackle cholesterol that's already in the system? We need a different strategy.
Let's move to the second class. Now, coming to the next slide, we have the bile acid binding resins. We call them the excretion enhancers.
The excretion enhancers. Their goal is to force the liver to consume more cholesterol by accelerating waste removal.
And their mechanism of action relies on a very clever trick involving the body's digestive cycle. So normally, the liver uses cholesterol to make bile acids,
which are released into the gut to help digest fat.
Correct. And critically, about 95% of those bile acids are then recycled back to the liver from the small intestine. It's a pathway called enterohepatic circulation, the liver being highly efficient.
And these resins interrupt that efficiency.
They do. These drugs are large, non-absorbable polymers that act like powerful bile acid magnets right inside your gut. They physically bind to the bile acids, forming this big, insoluble complex.
And because it's insoluble, it can't be reabsorbed.
Can't be reabsorbed. It's forced out and excreted in the stool, so the liver loses its efficient recycling loop.
So if the liver loses 95% of its recycled supply, it has to compensate by making brand new bile acids.
Yeah.
And where does it get the raw material?
It pulls it directly from the bloodstream, specifically from the LDL cholesterol circulating there.
It's a neat way to trick the liver into clearing more LDL from circulation.
Which results in lowered plasma LDL levels, and we have a simple mnemonic for these drugs. The three choles collect the bile.
The three choles, okay.
They are cholesterminin, cholestypol, and cholecivellum.
And since their action is entirely limited to the gut, I imagine their side effects are localized there too.
They are. Unfortunately, they often cause significant GI issues. They can be unpalatable to take. They cause bloating, gas, and severe constipation.
So compliance can be a real challenge.
A huge challenge. While they don't have that systemic risk of rhabdomyolysis, patients often just stop taking them because of the constant GI discomfort. They can also interfere with the absorption of other medications, so timing is critical.
Okay, let's shift our focus now. Moving away from LDL and toward the problem of those reserve fuel tanks, the triglycerides.
Right. So, now coming to the next slide. This brings us to class 3, the triglyceride tamers, or fibrates. These drugs are incredibly potent against high triglycerides, and their mechanism is much more comprehensive than just blocking one enzyme.
Their MOA is about activating a master switch for fat metabolism. And this switch is called PPAR-alpha.
PPA alpha. It stands for peroxisome proliferator activated receptor alpha.
Okay, that's a mouthful.
It is. But what it is a nuclear receptor. When it's activated by a fibrate, it goes into the cell's nucleus and actually changes gene expression. It literally reprograms the cells in the liver, fat tissue, muscle to be better at processing and burning fat.
Wow. So what are the actual effects of flipping this master switch?
First, it significantly increases the synthesis and activity of an enzyme called lipoprotein lipase, or LPL.
And what does LPL do?
LPL sits on the surface of your capillaries, and it literally strips triglycerides out of VLDL and other particles. More LPL means a much faster breakdown of circulating TGs.
So it just gobbles them up.
It does. Second, by clearing all that VLDL, the liver is forced to burn existing fats rather than synthesize new ones. So you get a dramatic decrease in plasma TG levels, often the biggest reduction we can achieve with any drug.
And there's a bonus effect, too.
A great bonus. It often leads to a moderate increase in HDL levels. So fibrates are powerful dual-action agents. They slash triglycerides, and they boost the cleanup crew.
The drugs themselves are easy to remember with a little trick.
They all contain Fib in their name. We have gemfibrozil, fenofibrate, bezafibrate, and clofibrate.
And their clinical use is clear-cut.
Very clear. They are the primary treatment for severe hypertriglyceridemia, especially in cases where TGs go over 500 milli-GDL. That carries a specific immediate risk of acute pancreatitis. These drugs are lifesavers in those scenarios.
What about safety? We talked about the risk of combining statins and fibrates.
Yes, since both can cause myopathy, combining them really raises the risk of muscle issues. Clinicians have to be very careful, often choosing a safer fibrate, like fenofibrate, and monitoring the patient very closely. And one other thing to note, clofibrate carries an increased risk of gallstones.
Okay, now let's talk about a hero that has a really unique superpower. It's the champion of the garbage truck system.
Now coming to the next slide, we're moving to class 4, niacin, also known as nicotinic acid or vitamin B3, and it is unequivocally the #1 most effective agent for raising HDL levels among the traditional classes.
So let's look at its MOA. It's wonderfully strategic. We call triglycerides the reserve fuel tank. Niacin's story is about stopping the fuel supply before it even leaves the tank.
That's a great way to put it. Niacin acts directly on the fat cells, the adipocytes. It inhibits a process called lipolysis.
Which is the breakdown of stored triglycerides into free fatty acids.
Exactly. It stops those free fatty acids from being released into the bloodstream. By reducing that stream of fuel flowing back to the liver is deprived of the building blocks it needs to make VLDL.
Less VLDL means lower triglycerides, and as a downstream effect, moderately lower LDL. But its unique power, the reason it's so important, is that potent, dose-dependent way it boosts HDL.
Often significantly more than any other drug class.
However, niacin has one major famous drawback that really impacts whether patients can stick with it: flushing.
This is a huge issue. Patients describe this intense burning sensation, warmth, and redness in the skin. It's mediated by the release of prostaglandins, and it can be so uncomfortable that people just stop taking the medication.
Which undermines the whole treatment plan. But there is a very well-known hack for this. This is the kind of practical nugget listeners need.
Yes, the intense flushing can be significantly mitigated by taking a low dose of aspirin about 30 minutes before the niacin dose.
And why does that work?
Because aspirin is a prostaglandin inhibitor. By blocking the synthesis of the very compounds causing the flushing, you dramatically reduce the discomfort and you boost compliance. It's a simple intervention with a massive clinical benefit.
Beyond flushing, we have to consider other side effects. Niacin can cause dyspepsia, and it can also cause hyperuricemia.
That's a crucial one. Hyperuricemia means elevated uric acid levels, which can precipitate or worsen gout attacks.
So going back to that personalized approach, if a patient has high lipids and a history of gout, niacin's probably off the table.
Usually, yes. It forces a completely different treatment choice. And like statins, it also carries a risk of hepatotoxicity and is contraindicated in pregnancy.
So we've covered the 4 traditional pillars:
Mm-hmm.
statins, resins, fibrates, and niacin. Now let's get into the modern era, the gatekeepers and the new age warriors.
Now coming to the next slide, this is where we see drugs that target really unique steps in the metabolic process. They're often used when traditional therapy isn't enough.
First, we have ezetimibe, the intestinal gatekeeper. This drug has a beautifully simple, targeted mechanism of action.
Its MOA is incredibly specific. It blocks a transporter protein in the intestinal wall called NPC1L1. This transporter is responsible for absorbing both the cholesterol from your diet and the recycled biliary cholesterol from your gut.
So it's literally blocking the door, preventing entry. And importantly, it doesn't affect the production of cholesterol in the liver or the absorption of other things like fat-soluble vitamins or triglycerides.
It is exclusively targeting cholesterol absorption.
And because it works via a completely different pathway than statins.
It's often used synergistically. Combining ezetimibe with a statin provides an additive reduction in LDL. It can help clinicians reach target goals that a statin alone couldn't achieve, sometimes at safer, lower statin doses.
Okay, now we move to the true modern warriors, a completely new class of biotechnology. PCSK9 inhibitors. These are high-tech monoclonal antibodies.
With names like alirocumab and evolocumab. Their mechanism is one of the most exciting breakthroughs in this field in decades. And it builds directly on that feedback loop we discussed with statins.
So let's use an analogy. Remember those super effective LDL receptors, the vacuum cleaners on the liver surface?
Yes, they do their job beautifully, pulling LDL out of the blood. But there's a small, destructive protein called PCSK9. Think of it as the receptor janitor.
The receptor janitor, I like it.
After the LDL receptor captures its cargo and brings it inside the cell, PCSK9 tags that receptor for destruction. It basically rips the vacuum cleaner off the cell surface and throws it away.
So the PCSK9 inhibitors, these antibodies, they're the receptor savers.
They are the receptor savers. They bind specifically to that PCSK9 protein, tying up the janitor so he can't do his job.
By inhibiting PCSK9, the LDL receptors are spared from being destroyed.
They can stay on the liver surface for longer, they can recycle more often, and that drastically increases the liver's capacity to clear LDL from the blood.
The result is a profound, often unprecedented, reduction in LDL cholesterol. We're talking triple downward arrows on the summary table.
They're usually reserved for very high-risk patients who have failed to meet their LDL targets on maximum dose statins, or patients with genetic conditions like familial hypercholesterolemia.
And finally, in this section, we have to mention a common natural-based option, omega-3 fatty acids.
Right, the stuff found in high concentrations in fish oils.
And while you can get it over the counter, high-dose prescription forms are very effective for one specific purpose.
Treating hypertriglyceridemia. Their mechanism of action is actually similar to fibrates in that they activate that PPAR alpha master switch, though generally less potently. They're excellent for managing high triglycerides.
Okay, that gives us a complete picture of the landscape. 6 distinct classes, each targeting a different point in the lipid life cycle. Let's pull it all together.
So now coming to the next slide. This is our strategic overview, the grand summary table. This is the essential takeaway sheet.
We'll run through it quick. We start with the statins. Their primary target is LDL, 2 down arrows, the mechanism. Inhibits HMG-CoA reductase, key fact. Watch for the HMG side effects, hepatotoxicity, myopathy, GI.
Next, bile acid resins, target LDL, 1 down arrow, mechanism. They bind bile acids in the gut, forcing the liver to use up more cholesterol, key fact. The 3 choles collect the bile.
The fibrates. Their main target is triglycerides, 3 down arrows, and they boost HDL, 1 up arrow, mechanism. Activate the master switch, PPAR alpha, key fact. They all contain Fib in their name.
Then niacin, the undisputed champion for HDL, 2 up arrows, and it also lowers TGs. Mechanism. Inhibits lipolysis in fat tissue. Key fact. It's the #1 drug for raising HDL, and aspirin can help with the flushing.
Ezetimibe. Targets LDL, 1 down arrow. Mechanism. Inhibits the NPC1L1 transporter in the intestine. Key fact. It's the intestinal gatekeeper, often used with statins.
And our newest, most powerful weapons, the PCSK9 inhibitors, target LDL, 3 down arrows, mechanism. They inhibit the degradation of LDL receptors. Key fact. The CUMAB antibodies, the receptor savers.
What's remarkable is that this overview really shows that if a patient fails on one drug, we have 5 other completely different mechanisms to try. It really is a customized approach.
It is. And to solidify this, let's run through a few questions. Now, coming to the next slide, we can test your knowledge.
Okay, question 1. A patient's main problem is severe hypertriglyceridemia. TGs are dangerously high. Which class of drugs is most effective?
Question 2. What is the rate-limiting enzyme in cholesterol synthesis? Which drug class targets it? And what's the serious muscle-related adverse effect we discussed?
Question 3. You have a patient on a max-dose statin who is still above their LDL goal. You want to add a drug that works by blocking cholesterol absorption in the intestine. What drug would you choose?
And question 4. Which drug is the most effective agent for increasing HDL cholesterol, and what is the simple hack to mitigate its main side effect?
These questions really connect the mechanism to the clinic. So now coming to the final slide, let's quickly review the answers.
All right, answer 1. For severe hypertriglyceridemia, the fibrates, like fenofibrate, are most effective, and the immediate risk we're trying to prevent is acute pancreatitis.
Answer 2. The rate-limiting enzyme is HMG-CoA reductase, targeted by the statins. The most serious muscle adverse effect is rhabdomyolysis.
Answer 3. The drug that inhibits cholesterol absorption and is added to a statin is ezetimibe, the intestinal gatekeeper. It targets the NPC1L1 transporter.
And answer 4. Niacin is the most effective for raising HDL, and its primary side effect, flushing, can be reduced by taking aspirin 30 minutes beforehand.
So what's the big picture here? The final critical takeaway is that treating hyperlipidemia is absolutely not a one-size-fits-all approach.
You can't just throw a statin at every problem. The choice of hero depends entirely on the enemy you're fighting. Is it high LDL, high triglycerides, low HDL, or some combination?
And that choice is always constrained by patient tolerance, genetics, other conditions like gout, pregnancy, and potential drug interactions.
Modern medicine provides this incredibly powerful, targeted team of heroes. Whether we're blocking the liver's factory, boosting the garbage truck, or tying up the receptor janitor, the goal is the same.
It's to manage the lipid profile and safeguard long-term cardiovascular health.
We've spent our time today focusing on these powerful pharmacological agents, the interventions that happen once things are already out of sync. And this knowledge really empowers you to understand the complexity and the personalization of modern medical treatment.
But if we zoom out one last time, let's consider a final thought. If the ultimate goal is to optimize health by finding the perfect balance between the bricks and mortar and the fuel reserves, what does a truly proactive, personalized approach to prevention look like before these powerful heroes even need to be called into action?
It really forces us to confront that complex interplay between diet, our own individual genetics, and the environment that dictates our starting lipid profile in the first place. It's the very landscape upon which this entire clinical battle is fought. Understanding the drugs helps us appreciate the fragility of that initial balance.
Something for you to mull over until our next deep dive. Imagine this, the frantic rhythm of a trauma bay. You hear the monitors beeping faster, the voices rising in pitch. A patient, maybe from a major accident, severe burn, or massive internal bleed, is crashing.
Right.
They are rapidly losing their internal lifeline, and the clock is ticking down to 0. The immediate critical need is volume, but not just any volume.
No, it's not simply about replacing the red oxygen-carrying cells immediately, though that is, the ultimate goal. The primary minute-by-minute failure is hydraulic. The body's entire circulatory system, this complex plumbing network, is failing because there isn't enough pressure or fluid to maintain flow.
Yeah.
You have to stabilize the system now if you want the residual oxygen to reach the vital organs before they begin to fail.
And that right there is the crucial challenge and the focus of this deep dive. We are going straight into the critical care world to unpack hypovolemic shock, the failure caused by low volume, and examine the crucial molecular tools used to fight it. Plasma volume expanders, which you might know as colloids.
We have 15 crucial concepts laid out beautifully in the source material to guide us. Think of this as a detailed tour of emergency pharmacology and sophisticated physiological fluid dynamics. We're going to break down the physics,
Right.
introduce the molecular sponges, identify the gold standards and the essential workhorses, and conduct postmortems on the agents that were ultimately benched due to fatal safety concerns.
So our mission is to give you not just the facts, but the deep why behind the clinical decision-making. We'll be using clear structure, powerful analogies, and the knowledge of which fluids are absolute lifesavers.
And which ones are frankly dangerous in the wrong situation.
Get ready, because we are diving deep into the world where molecular size dictates survival.
Okay, let's get into it.
All right, let's unpack this with our first foundational concept, which really sets the scene. Now, coming to our first slide, the body's lifeline is failing. We start with this plumbing analogy to understand hypovolemic shock. So what does hypovolemic actually mean in a life or death context?
Well, hypo means low, and vol means volume. So hypovolemic is just the clinical term for low circulating volume. When we're talking about shock, we mean the body has suffered a catastrophic loss of fluid, often very, very rapidly.
From what kind of causes?
It could be trauma, hemorrhage, severe dehydration, or massive fluid shifts like you see in extensive burns.
So if we visualize the circulatory system as this vast pressurized network of pipes, the fluid level suddenly drops drastically because of a huge leak somewhere.
Exactly. And that volume drop initiates a catastrophic physiological cascade.
What's the immediate measurable consequence of that drop in volume? What's the first thing you'd see on a monitor?
The first thing to fall is blood pressure, or BP. Since there's less fluid pushing against the walls of the blood vessels, the pressure needed to perfuse the organs, to push blood flow into tissues like the brain and kidneys, it just tanks immediately.
And the body doesn't just sit there and take it, right? It tries to fight back.
Oh, absolutely. The body's immediate frantic response is to trigger the sympathetic nervous system, our fight-or-flight mechanism, to try and compensate.
I see. So the heart tries to fix the problem by going into overdrive.
Precisely. The heart starts beating faster, a clinical sign called tachycardia, trying to compensate for the plummeting pressure by increasing the rate of flow. It's like turning up the speed on a failing water pump.
And what about the pipes themselves, the blood vessels?
At the same time, the body clamps down on peripheral blood vessels. That's vasoconstriction. In non-essential areas like your skin and your gut, trying to shunt what little volume is left toward the brain and the heart.
But as we mentioned before, if the river is too low, just speeding up the pump doesn't really help you get across the river.
That's the critical physiological failure. Despite the heroic efforts of the heart and the blood vessels, there just isn't enough fluid or pressure to maintain oxygen delivery. The system is starving the organs.
And the clock is ticking.
A very fast clock. If this volume isn't restored immediately, and we're talking minutes, not hours, the kidneys begin to shut down, the liver stops processing toxins, and eventually the brain suffers. This failure leads to systemic cellular death and metabolic acidosis.
Which is why immediate fluid resuscitation is the absolute cornerstone of trauma and shock management.
It's everything.
Okay, so now that we understand the crisis, we need to know what we are putting back in. So now coming to the next slide, let's look at the composition of blood and what exactly is lost during shock.
Right. Before we figure out what fluid to infuse, we have to understand what fluid makes up blood volume. When you draw blood and spin it in a centrifuge, that classic test tube view, you see two very distinct layers.
The bottom 45% is what most people think of as blood, the red stuff. I think you called this the cargo in our prep.
Yes, that's a great way to think of it. That's where the heavy lifting happens. The cargo is primarily the red blood cells, our oxygen taxes, which are crucial for delivering life-sustaining gas to the tissues.
And it also has the repair crew.
The repair crew, right? The white blood cells and platelets, which are busy fighting infection and forming clots.
Okay, and the remaining 55% is that pale, straw-colored liquid above it.
That's the river. Plasma. This is the liquid superhighway that provides the volume and the fluidity necessary for the cargo to move.
So it's mostly water.
It is. Plasma is predominantly water, over 90%, but dissolved within it are crucial proteins, most importantly albumin, along with salts, electrolytes, nutrients, and hormones. This liquid component ensures the entire system has the necessary hydraulic pressure to keep flowing.
So if the failure is based on low volume, where does the loss occur? When you have a massive bleed, you're losing everything, cargo and river. But in many forms of shock, like, say, the early stages of severe sepsis or burns, the system gets incredibly leaky and we primarily lose.
We lose the river itself, the plasma volume, faster than the cargo.
Can you give an example of that?
Sure. In burn shock, for example, the capillaries become so permeable that the plasma rapidly leaks out into the interstitial space. This causes massive edema or swelling and a critical drop in circulating volume, even if the patient hasn't externally bled a single drop.
Wow. So the immediate non-negotiable goal in these scenarios is restoring that river and the pressure it provides.
That's job one. Refill the river.
Okay, if plasma is the river we're trying to refill and volume is the core problem, our first tool for volume replacement is often just simple water and salt. Now, coming to the next slide, let's look at why that simple solution, crystalloids, is often not enough for severe ongoing shock.
Right. When a patient arrives in shock, the immediate go-to, the fundamental first line of defense is crystalloids.
Now, what are those exactly?
These are the simple salt-based solutions, like normal saline, which is just salt water, or Ringer's lactate. They are ubiquitous, they're cheap, and they're stable.
So they're essentially water with electrolytes added to mimic the body's natural salinity. Tell us about their mechanism of action when you infuse them.
When you pour these crystalloids rapidly into the bloodstream, they do increase the volume inside the blood vessels almost instantly. You get a quick rise in pressure, They are absolutely critical for that immediate stabilization.
So they are like pouring water into the leaky pipe system to try and quickly maintain pressure. So what's the downside? What's the catch?
The critical drawback relates to their size and the physics of fluid dynamics, specifically something called Starling's law. The molecules in crystalloids, sodium chloride lactate, are tiny.
And our blood vessels, the capillaries, are semi-permeable pipes, right?
Exactly. In a healthy state, there's a balance of pressure. Hydrostatic pressure, which is the force pushing fluid out, and oncotic pressure, the force pulling fluid in.
In shock.
In shock, especially with inflammation, the capillaries become even leakier, and the hydrostatic pressure generated by that rapid infusion pushes those small crystalloid molecules right out of the vessel pores and into the surrounding tissues. This process is called extravasation.
So while they're a rapid initial fix, they don't stay in the circulation. How much volume actually remains in the pipes after, say, an hour?
Unfortunately, not much. Depending on the fluid and the patient's condition, studies suggest that 60 to 80% of the infused crystalloid volume has shifted out of the vascular space and into the interstitial space within 30 to 60 minutes.
That's incredible. So for every liter you infuse, only maybe 200 to 400 milliliters are actually staying in the pipes where the pressure is needed.
Precisely. And that massive volume leaving the pipes results in the complication we often see: tissue swelling or edema.
So you're forced to administer enormous volumes of fluid liters upon liters just to maintain a temporary pressure.
And that carries a huge risk of complications, including diluting the patient's own clotting factors and proteins. For severe, sustained volume loss, crystalloids simply don't have the staying power to win the fight. We need agents that are designed to remain within the circulation.
If crystalloids are too small and leak out, we need to bring in the heavy hitters. So now coming to our next slide, this is where we call in the specialists, colloids, the plasma volume expanders.
When simple salts fail to provide sustained resuscitation, we deploy agents that fundamentally alter the hydraulic balance. Colloids are solutions containing large molecular weight particles, and their secret weapon is oncotic pressure.
Let's define that difference using a visual analogy. If crystalloids are like sand flowing easily through a sieve, what are colloids?
Colloids are large, robust molecules. You can think of them as molecular boulders, or even better, molecular sponges. Because they are so large, they cannot easily pass through the semi-permeable walls of the capillaries. They stay inside the circulatory pipes where the pressure is needed.
And their job goes beyond just adding volume, right? They are active participants in fluid movement.
Absolutely. They don't just fill the bucket, they act as powerful magnets for water.
How does that work?
By increasing the concentration of these large solutes inside the blood vessel, they create a strong osmotic gradient. This actively pulls fluid from the surrounding tissues, that interstitial space where the extravasated crystalloids often sit back into the bloodstream.
And that's colloidal oncotic pressure.
That is the definition of colloidal oncotic pressure: the ability to generate a powerful, sustained pull on water.
So instead of just pouring into a leaky system, you are administering a solution that increases volume while simultaneously recovering fluid that had previously leaked out.
That sounds like a much more efficient use of administered volume.
It is far more efficient. The result is a much more powerful and, crucially, a longer-lasting expansion of plasma volume with a significantly smaller total volume of fluid administered. This buys critical time, minimizes the risk of generalized tissue swelling, and stabilizes the patient faster.
Okay, if colloids are these highly efficient molecular sponges, and they are so much more effective at generating oncotic pressure than crystalloids, why aren't we using them exclusively right from the start in every shock scenario? Well, that comes down almost entirely to two major factors: cost and logistics. Colloids are significantly more expensive than simple salt solutions. Albumin, the natural gold standard, is donor-dependent.
And the synthetics.
They require complex manufacturing. Crystalloids, being just simple water and salt, are dirt cheap and available everywhere, including in remote settings or on the back of an ambulance. So the decision to escalate to colloids involves balancing their superior physiological effectiveness against their high cost and supply chain challenges.
That sets the financial stage. Before we meet the candidates, we need to know the standards they must meet to justify that high price tag. Now, coming to the next slide, let's look at the job description for a lifesaver.
Right. If you were hiring a plasma expander to save a life, the interview process is extremely rigorous. We can break the ideal candidate down into 5 non-negotiable categories that cover compatibility, duration, safety, logistics, and procedural integrity.
Let's start with criterion 1, perfect match. What does it mean for a fluid to blend in perfectly?
It means its physical properties must be pretty much indistinguishable from human plasma. Specifically, its oncotic pressure needs to match, ensuring it pulls fluid effectively without causing dangerous fluid shifts.
And its pH.
Its pH must be neutral to prevent systemic acid-base problems. And importantly, its viscosity, how thick or thin it is, must not impede flow. If the solution is too viscous, it actually slows down microcirculation, which defeats the whole purpose of resuscitation.
Criterion 2 addresses persistence, stays on the job. We need sustained volume support.
Exactly. We need a good biological half-life. It must be retained in circulation for an adequate period of hours, ideally, to allow the body time to recover, or for clinicians to prepare definitive treatments, like blood transfusions. If the expander clears from the circulation too quickly, you're right back to square one.
Next, plays well with others. This is about avoiding systemic biological conflict.
This has dual requirements for safety. First, it must be non-pyrogenic. It cannot cause a fever. A fever in a critically ill patient can worsen their metabolic demand and be very misleading clinically.
And the second part is even more important, I imagine.
It is. More critically, it must be non-antigenic. It absolutely cannot trigger a massive, life-threatening immune or allergic reaction. Since many of these are large molecules or derived from foreign sources like bacteria or animals, ensuring non-antigenicity requires extremely rigorous processing and purification. The patient's compromised system must accept this fluid as a friendly guest, not an intruder.
Number 4 is the practical global factor, ready and reliable.
Life-saving drugs have to be logistically simple. They need to be stable at room temperature, which eliminates the need for complex, expensive refrigeration. That's vital for military use, ambulance services, or in low-resource settings. And yes, they should be relatively cheap, allowing for widespread use when massive volumes are needed.
Finally, the critical, absolutely non-negotiable fifth point, the integrity test, doesn't cause confusion. Why is it paramount that the expander must not interfere with blood grouping and cross-matching?
This is the single most critical procedural safety rule, especially in severe trauma. The expander is only a bridge. The ultimate treatment for severe hemorrhage is replacing the oxygen-carrying red blood cells via transfusion.
And to do that safely.
To do that safely, the lab must confirm the patient's blood type and compatibility with the donor unit. If the expander contaminates the blood sample, physically blocking the lab from reading the results, you introduce a catastrophic, life-threatening delay in providing the definitive treatment. Any expander that fails this test, even if it's otherwise effective, is highly compromised in the trauma setting.
That sets the stage perfectly. We are looking for high oncotic power, long duration, zero allergy risk, logistical simplicity, and non-interference with the lab. So now coming to the next slide, let's introduce the molecular candidates and see which ones come closest to perfection.
All right, let's meet them.
We begin with the one who sets the bar, the benchmark, the natural candidate, human albumin. It is prepared directly from pooled, donated human plasma.
Albumin is truly the gold standard because it is the body's own natural system. Albumin is the most abundant protein in plasma, and it's responsible for roughly 80% of the natural oncotic pressure we rely on. When we administer it, we're directly restoring that natural function. You can't get more biologically compatible than this.
And it has impressive potency, which speaks to its molecular efficiency.
Absolutely. The source material highlights that a small amount has a massive effect. 25 grams of a 5% albumin solution is osmotically equivalent to a staggering 500 milliliters of fresh frozen plasma.
Wow, so you get half a liter's worth of oncotic pull from a very small infusion bottle.
A massive punch, yes. And that makes it ideal for specific severe conditions.
What are albumin's prime mission profiles where its natural function is indispensable?
It's the preferred agent for restoring volume in hypovolemic states, especially those related to large-scale protein loss. Think severe, extensive burns, severe hemorrhage, and major surgery. It's also often preferred in patients with liver failure, where the body can't produce its own albumin.
Let's break down the pros and cons of this gold standard. What are the pros?
The pros are its natural efficacy and its safety from viral transmission like hepatitis B, C, and HIV, due to the mandatory pasteurization process it undergoes during manufacturing.
And the cons?
Well, the cons are major logistical and cost hurdles. Being so potent, there's always a caution around rapid infusion potentially causing fluid overload, especially in patients who may have underlying heart weakness.
But the biggest issue is availability, right?
That's the one.
Huh.
It is incredibly expensive, and its availability is entirely dependent on the continuous supply of screened, donated human plasma.
That dependency makes the search for synthetic alternatives essential for widespread and cost-effective use.
Precise. I mean, if we can find a synthetic molecule that hits 90% of albumin's performance at 10% of the cost, that is a global medical revolution.
And that leads us perfectly to our next slide. Let's talk about dextrin, the synthetic workhorse. It's a water-soluble polymer of glucose produced by specific bacteria grown on sucrose. So it's a controlled biological product that we've engineered for medical use.
Dextrin is powerful, and clinicians must know its twin personalities. It comes in two primary sizes, which dictate its clinical application, its speed, and its duration.
Okay, we have dextrin 40 and dextrin 70. How do the numbers define their mission profile?
Dextrin 40 is a 10% solution, and because it's the smaller molecule, it's the sprinter. It acts very rapidly, giving a huge quick boost of volume, but because the kidneys clear the smaller molecules quickly, the effect is short and transient.
And what is dextrin 40's special skill beyond that quick volume boost?
Its small size gives it a massive advantage in the microcirculation. It improves flow by coating the red blood cells, reducing blood viscosity, and preventing red blood cell sludging, where the cells kind of clump up in the tiny capillaries.
And why is that important?
It's critical in conditions where blood flow is sluggish, like severe shock or certain vascular surgeries.
Okay, then we have dextrin 70.
Dextrin 70 is the larger molecule, a 6% solution. Since the kidneys clear it much more slowly, it's the marathon runner. It provides a longer, more sustained duration of action, preferred when you need smaller volumes. But the effect must last for hours.
We need to lock in that distinction because it's a high-stakes choice between rapid onset and sustained duration.
Right, and the learning hack works perfectly here.
Which is?
Dextrin 40 is for the 40-yard dash. It's fast and short-lived.
And dextrin 70 runs a 70-mile race. It's slower to clear and therefore longer lasting.
Exactly.
Dextrin might be an effective workhorse, but now we hit the critical segment. Now coming to our next slide, we have the dextrin danger zone. This covers the massive asterisk attached to its use.
Yeah, dextrin is effective, but it is not chemically inert. And the biggest risk, the career-limiting move in trauma care, is blood-matching mayhem. The source material clearly states that dextrin causes red blood cells to stack together like coins, a phenomenon called rouleau formation.
Like a roll of coins. And why is that stacking a monumental problem for the laboratory?
Well, standard blood grouping and cross-matching tests rely on the lab being able to visually observe whether antibodies in the serum cause the red cells to agglutinate or clump unevenly when mixed with donor blood.
But dextrin interferes with that.
Dextrin's coating forces the cells to stack neatly, physically interfering with the test. The technician can't tell if the cells are clumping due to dextrin or due to a life-threatening incompatibility reaction. The sample becomes unreadable.
This circles back directly to our job description criterion 5. Don't cause confusion. If you suspect you might need to give dextrin, there is a fundamental safety step that cannot be skipped. What is the critical rule?
You must always draw blood for the lab, for grouping and cross-matching, before administering dextrin. If you forget this rule, you have chemically contaminated the sample, delaying the patient's definitive treatment.
Let's assume a critical trauma patient is bleeding out. What is the actual consequence of forgetting that critical rule and giving dextrin first?
That small oversight stops everything. The clock is ticking down. The patient needs O-negative or typed blood now to restore oxygen capacity. If the lab calls back and says the sample is contaminated, we can't cross-match, you've added a potentially fatal 30 to 60-minute delay while a fresh sample is drawn, sent, and processed.
You've turned your temporary bridge into a dangerous roadblock.
Sacrificing procedural integrity for a temporary volume gain. It's a huge mistake.
What are the other dangers in the dextrin danger zone?
We have a significant bleeding risk. Dextrin coats not only red cells but also platelets, interfering with their sticky function, the body's natural mechanism for forming clots. It interferes with overall blood coagulation.
And if the patient is on other medications?
If the patient is already on blood thinners like heparin, dextrin enhances that effect, significantly raising the risk of catastrophic bleeding. Finally, allergic reactions, particularly anaphylaxis, are rare but possible.
So dextrin is potent for microcirculation and fast volume, but its risks necessitate extreme procedural caution. If we need a sturdy synthetic without that critical blood matching failure, where do we look next?
Okay, now coming to our next slide. We turn to hydroxyethyl starch, or HEDA starch, HES, the modern starch. This is a synthetic molecule derived from starch, modified to act as a powerful colloid.
Beta starch was designed to mimic albumin's core mechanism, but avoids the donor dependency and, crucially, the chemical interference of dextrin.
Correct. HES acts by generating strong oncotic pressure, similar to albumin. Its design ensures two huge professional advantages. First, it is long-acting and stable at room temperature, ticking the box for logistical simplicity.
And the second, more important one.
Second, and most critically, it does not interfere with blood grouping and cross-matching. In many trauma centers, this non-interference immediately makes HES the preferred synthetic over dextrin.
We noted that HEDA starch has a special use case beyond standard volume expansion. What is leukapheresis?
Leukapheresis is a procedure used to selectively harvest white blood cells, specifically granulocytes, from a patient, often for donation or certain cancer treatments. HES is used here because its molecular properties influence the blood flow, helping to cause a temporary separation or clumping of the white cells. This makes the mechanical separation process in the apheresis machine much more efficient.
So it increases the yield of the target cells.
Exactly.
That's fascinating, a benefit entirely unrelated to trauma resuscitation. So what are the drawbacks of this otherwise sturdy synthetic?
While it avoids the blood matching issue, HES has its own list of side effects. Patients can experience a flu-like syndrome, including headaches and muscle aches. A persistent and irritating complication is intense generalized itching or pruritus, which can last for days or even weeks after administration.
And what about more serious concerns?
Like all foreign agents, anaphylactoid reactions are a risk. And there have been clinical controversies in the last decade regarding the use of HES in septic patients, with some data suggesting an increased risk of acute kidney injury compared to crystalloids. This has prompted many clinicians to use it much more cautiously, even though it excels in trauma volume expansion.
Moving on, now coming to the next slide, we've covered natural proteins, bacterial sugars, and starches. Next is the animal source contender, degraded gelatin polymer. This is a polypeptide created from purified ox or cattle collagen.
It's essentially high-tech gelatin, and its advantage lies in its accessibility and relatively low cost compared to albumin. This agent exerts oncotic pressure effectively, similar to plasma proteins, and it provides volume expansion for a respectable duration, often up to 12 hours.
What's its unique skill that distinguishes it from the others?
Well, it possesses a unique characteristic. Unlike dextrin, which increases bleeding risk, degraded gelatin polymer has sometimes been noted for its hemostatic potential.
Meaning it helps control bleeding.
In certain surgical contexts, it has been used to help control bleeding, which is a massive bonus in a hemorrhage scenario.
So the package is appealing. Effective duration, no interference with blood matching, and potentially helpful in stopping bleeding. What are the cons of the collagen contender?
The primary concern is linked back to its animal origin and its nature as a foreign polypeptide. It carries a significant risk of allergic-type reactions. Clinicians have to watch for flushing, intense itching, and drops in blood pressure or hypotension.
And have there been specific formulations that were more problematic?
Yes, some older cross-linked formulations like Hamicel were specifically linked to a higher rate of severe reactions, requiring careful selection of the modern, safer formulations.
This is a classic case study in medical pharmacology. Not all candidates make the cut, no matter how good they look on paper. So now coming to our next slide, let's talk about polyvinyl pyrrolidone, or PVP, the retired agent.
Yes, PVP is a synthetic polymer that is now rarely used, and it offers the perfect negative case study. It proves that sometimes the biggest danger isn't a lack of efficacy, but a lack of chemical integrity.
When we reviewed the job description, point 5 was non-negotiable. Doesn't cause confusion. PVP didn't just fail that test, it became actively hostile. Why was it benched?
The first failure was similar to dextrin. It interferes with blood grouping and cross-matching. This alone is grounds for withdrawal from trauma settings. But the second issue is even more alarming, which we call the drug hijacker effect.
The drug hijacker. Explain how it earned that alarming title.
PVP is not chemically inert. It actively and indiscriminately binds to other essential circulating drugs, specifically insulin and penicillin. This competitive binding reduces the amount of free active drug available in the circulation.
That's a catastrophic domino effect. So if a patient is septic and needs a crucial antibiotic like penicillin, or if they are diabetic and need active insulin, and the volume expander renders the drug partially useless?
You've accidentally caused a secondary, potentially fatal complication, a treatment failure in an entirely different system.
The lesson is profound.
It is. An expander's job is purely to expand volume and be chemically ignored by the body. Interfering with essential body processes or diagnostic tests, even if it's effective at volume expansion, is an immediate critical failure that warrants withdrawal from clinical use.
A fascinating history lesson. Before we compare the winners and losers head-to-head, now coming to the next slide, let's talk about the absolute no-go zones, the patients for whom any expander is dangerous.
Right. We have spent extensive time discussing how these fluids save lives, but it is equally, if not more, important to understand the absolute contraindications. Giving the wrong expander to the wrong patient transforms a treatment into a life-threatening mistake.
Let's go through the 4 absolute contraindications, starting with severe anemia. Why can't we just give an expander to a severely anemic patient?
Remember the fundamental rule. Expanders fill the river, but they don't carry the cargo oxygen. If a patient is severely anemic, they are critically low on their oxygen taxes, their red blood cells.
And if you pump in an expander,
You dramatically increase the volume of the river, but you simultaneously dilute the few remaining oxygen taxes.
so you improve the hydraulic pressure, but you make the oxygen delivery problem, the underlying cause of the organ failure, worse.
Precisely. You worsen the oxygen carrying capacity, accelerating the crisis at the cellular level. This is why a severely anemic patient needs a blood transfusion, cargo replacement, not just volume expansion, as their definitive treatment.
Next, congestive heart failure, CHF. This seems like a straightforward hydraulic problem. The heart is already failing.
It is the ultimate hydraulic paradox. In CHF, the heart is a weakened, failing pump, struggling to maintain its current workload. If you introduce a plasma expander, an agent designed to powerfully draw fluid into the circulation and significantly increase total fluid volume,
You're just overloading it.
you are fundamentally overloading that failing pump with more fluid than it can handle.
And what is the clinical consequence of that overload in a CHF patient?
The excess volume backs up into the circulation, primarily into the lungs. This is called pulmonary edema fluid filling the air sacs. The increased hydrostatic pressure in the lung capillaries overwhelms the oncotic pressure, pushing water into the delicate lung tissue. The patient essentially begins to drown in their own fluid.
It's a critical mistake.
An absolute contraindication. The heart cannot handle the increased preload.
What about bleeding disorders? We know dextrin is problematic, but is this a general caution?
It remains a generalized caution, but it is most acute with the synthetic sugars like dextrin and starches like HES. Since some expanders can impair coagulation factors or platelet function, administering them to someone with a pre-existing bleeding disorder like hemophilia, or a patient receiving large doses of anticoagulants, can severely exacerbate the bleeding.
You'd be worsening the cause of the volume loss.
Exactly.
And finally, renal and hepatic failure. The body's processing plants are shut down.
Correct. The patient's kidneys and liver are responsible for processing, filtering, and clearing both the excess fluid and the large synthetic molecules we administer. If the kidneys are failing, they cannot excrete the water or the solutes. If the liver is failing, it cannot process the molecules that rely on the reticuloendothelial system for clearance.
So, if the organs can't clear the fluid or the large molecules, where do they go?
They remain trapped in the circulation, causing dangerous fluid overload, electrolyte imbalances, and sustained, sometimes toxic levels of the polymer molecules in the blood. The expander needs an exit route. If the processing organs are shut down, the expander becomes a compounding problem, not a solution.
That's an essential set of cautions. So now, coming to our next slide, let's take a moment to synthesize everything we've learned. This head-to-head comparison chart is the ultimate learning hack for quick recall. We're looking at the origin, the feature, the impact on cross-match, and most importantly, the cautions.
Right, we need to nail the distinguishing factors, especially the compatibility issues.
Okay, start with human albumin. Origin, natural, from human plasma. Feature, the gold standard naturally restores 80% of oncotic pressure. Impact on cross-match, none. Major caution, hypersensitivity and high-cost donor dependency.
Next, dextrin. Origin, synthetic, derived from bacterial sugar. Feature, the sugar workhorse, specialized for microcirculation improvement, impact on crossmatch. Critical interference due to rouleau formation. Major caution. severe bleeding risk, and anaphylaxis.
Then, head of starch, HES. Origin, synthetic, derived from starch. Feature, the sturdy synthetic, stable and non-interfering. Impact on crossmatch, none. Major caution, itching or pruritus, and clinical concerns regarding kidney safety in septic patients.
Our animal-based agent, gelatin polymer. Origin, animal from ox collagen. Feature, the collagen contender known for its 12-hour duration and potential hemostatic benefit. Impact on crossmatch, none. Major caution, allergic reactions due to its foreign protein structure.
And finally, the case study in failure, PVP. Origin, synthetic polymer. Feature, the retired agent. Impact on crossmatch, interferes. Major caution, the drug hijacker, it binds to and inactivates essential medications like insulin and penicillin.
Seeing them mapped out like this really confirms it. Only dextrin and PVP fail that basic procedural integrity test, making them high-risk choices in the time-sensitive trauma environment. Albumin and the others maintain a clear path to definitive blood transfusion.
Okay, time to apply this comprehensive knowledge. Now, coming to our final slide for discussion, the field test. We're moving from recall to application and synthesis. Let's start with a level 1 recall question to test the core safety rule.
Okay, level 1, recall question and answer. A patient in shock needs volume, but the medical team must secure the patient's blood type first. Which plasma expander is most notorious for physically interfering with blood cross-matching tests in the lab?
That one is definitely dextrin. The rouleau formation, that stacking of the red blood cells, makes the sample unreadable for the lab technician, causing a severe, potentially fatal delay in safe transfusion. It's the one where we enforce that absolute critical rule: draw blood before you start the infusion.
Perfect recall.
Oh!
Now let's elevate this to level 2, an application question, connecting the treatment to the underlying patient history and those critical contraindications.
Hey, hit me.
Level 2, application question and answer. You have 2 patients who need immediate volume expansion due to severe third-degree burns. Patient A has no prior medical history. Patient B has severe burns. A and D, a confirmed history of chronic congestive heart failure, CHF, for which patient is a plasma expander contraindicated and why.
Okay, the answer has to be patient B. The reasoning is tied directly to the pathophysiology of heart failure. Patient B already has a heart struggling to manage normal fluid dynamics, so giving them a plasma expander, which powerfully pulls even more fluid into the blood vessels, would dramatically increase the preload. That failing heart just can't handle the sudden influx of volume, and the consequence would be dangerous pulmonary edema, fluid backing up into the lungs. The life-saving fluid for patient A would be life-threatening for patient B.
That is where the high-stakes clinical decision-making happens. Knowing the patient's underlying condition is just as important as knowing the drug's mechanism. Now for the toughest one, level 3, synthesis. This requires connecting the immediate action of the expander to the ultimate goal of trauma care.
Let's do it.
Level 3, synthesis question and answer. Why does not interfere with blood grouping considered a critical feature for an ideal plasma expander, especially in a trauma setting?
The ultimate answer is that in trauma, the goal for severe hemorrhage is to give whole blood. The expander is just a temporary bridge. It's not the final destination.
And so,
if the expander interferes with cross-matching, it delays the safe administration of definitive blood. It blocks the path to the final destination. You're essentially building a bridge that collapses right before you get to the other side.
perfectly synthesized. The right molecular tool manages pressure and volume more efficiently, acting as a true helper, never a hindrance, in the fight against shock.
We've seen the molecular sponges, the dash runners, the marathon runners, the gold standards, and the retired agents. We've broken down the physiology of a circulatory crisis, the physics of oncotic pressure, and the critical rules of compatibility.
The major takeaway is clear. Fluid resuscitation is not about guessing. It requires precise knowledge of what the body is losing and what molecules will stay in the game long enough to make a fundamental difference.
Understanding these molecular distinctions, why a small crystalloid leaks out while a massive colloid stays put, or why one synthetic sugar causes blood matching failures while another synthetic starch does not, is literally the difference between successful and failed critical care.
It really is. It shows us that even seemingly simple solutions, like just adding water, require a deep physiological and pharmacological understanding to be applied safely and effectively.
As we wrap up, we learned that human albumin is the natural gold standard, unmatched in biological compatibility. But it is expensive and fundamentally dependent on human donors. Given the critical warnings and safety challenges associated with current synthetic agents like dextrin and even hetastarch, here's something for you to mull over.
What's that?
What future bioengineered molecule could completely replace albumin?
That's a great question. Could modern biotechnology develop a synthetic polymer, perhaps one built entirely from amino acids or engineered starch, that perfectly mimics albumin's size, stability, and lack of antigenicity while remaining cheap, stable, and widely available? What would that molecular breakthrough look like, and how would achieving this synthetic perfect candidate transform emergency medicine globally?
Ensuring every trauma bay in the world has access to the gold standard. A completely synthetic molecular sponge that solves all the problems. Something to think about next time you consider the delicate balance between volume, pressure, and life itself. Thank you for joining this deep dive.